Good morning, everyone. I'd like to welcome everyone to the public meeting on behalf of the National Academies of Science, Engineering, and Medicine. I am Dr. Linda McCauley, and my colleague, Dr. Bob Phillips, and I are co-chairs of this ad hoc committee on implementing high-quality primary care. I wish to recognize our fellow committee members who are volunteering for this study. They're joining us today from all over the United States. After I call on you, please say your name and affiliation. Asif, are you muted? Let's go on. Tumami Coker?
Seattle Children's Hospital.
Carrie Cola?
Good morning, everyone. Carrie Cola. I'm a health economist from Dartmouth College. Good morning.
Molly Cook?
Hello, everyone. My name is Molly Cook. I'm a primary care or general internist at UCSF.
Jennifer DeVoe?
Hi, Jen DeVoe, family physician, chair of the Department of Family Medicine at Oregon Health and Science University.
Rebecca Etz?
Hi, everyone. Rebecca Etz. I am an associate professor of family medicine and population health at VCU and co-director of the Larry Green Center.
Susan Fisher Owens? Jackson Greggs?
Hey there, Jackson Greggs. I'm a family doctor and the CEO of Heart of Texas Community Health Center in Waco, Texas.
Bob Phillips?
Bob Phillips, family physician, American Board of Family Medicine in Washington, D.C.
Shauna Hudson?
Good morning, Shauna Hudson, research professor and as well research division chief in the Department of Family Medicine Community Health at Rutgers University, New Jersey.
Thank you. Shara Kambogi?
Hi, everybody. This is Shreya Kangovi. I'm an internist and pediatrician and on faculty at the University of Pennsylvania and the founding executive director of the Penn Center for Community Health Workers.
Chris Kohler?
Good morning. It's Chris Kohler, president of the Milbank Memorial Fund.
Alex Christ?
Hi, Alex Christ, family physician at Virginia Commonwealth University.
Lucy Lakram?
Hi, it's Lucy. I'm a general internist and health services researcher at Dell Medical School at UT Austin and in the South Texas Veterans Healthcare System.
Mary McClurg?
Hi, I'm Mary McClurg, professor and vice dean at the UNC Eshelman School of Pharmacy at the University of North Carolina, Chapel Hill.
Ben Olmedo?
Hello, my name is Ben Olmedo. I'm a primary care physician assistant, and I do a little bit of primary care, urgent care, and clinical informatics at Dignity Healthcare in California. Thanks.
Brenda Reese Brennan?
Good morning, everyone. I'm Brenda. I'm at Intermountain Healthcare, a psychiatric nurse practitioner and medical anthropologist working in primary care for over 40 years.
Hector Rodriguez?
Hi there, Hector Rodriguez, Professor of Health Policy and Management at the UC Berkeley School of Public Health.
And Robert Wyatt?
Good morning, I'm Bob Wyatt. I'm a Professor of Epidemiology and Dental Public Health at the University of Pittsburgh.
Dr. Bidden, is Dr. Bidden on? Okay, well, let's go on. I also want to acknowledge the study staff, Mark Meisner, who's serving as the study director, Cheryl Nass, who's director of the Board of Healthcare Services, Lucy Lustig, Sarah Robinson, Samira Abbas, as well as National Academy of Medicine Fellows, Cameron Matthews, Bim Aquedo, and Lars Peterson, and the National Academy's Mirzian Fellow, Jennifer Pathodi. It's with their help that we're able to do this important work. Also, I want to acknowledge our important study sponsors with whom we will engage in this public meeting and whose generous support has made this important work possible. This slide shows all the multiple sponsors of this study. This is our second open session. Over the course of the study, the committee will examine the current state of primary care in the United States and develop an implementation plan to build upon the recommendations from the 1996 IOM report titled Primary Care, America's Health in a New Era. We're going to develop recommendations to strengthen primary care services in the United States, especially for underserved populations, and to inform primary care systems around the world. More information about the statement of tasks of this committee can be found on the project website. I think we have a slide with the project website coming up for those of you in our public audience. So I want to, that website is National Academies, one word, .org/primary care. I would also like to give some sense of the format of today's meeting, what our agenda will be. I think we have a slide of the agenda for the day. Here we go. So we're going to start with a short presentation from Christine Bechtel on patient perspectives in primary care. We will then have two separate panels, one on policy change in primary care, the challenges, the realities, and opportunities that we're facing, and then a second panel on the delivery system innovation, challenges, and opportunities. Opening presentation and each panel is going to be followed by question and answer from committee members. Then we will end the session with a brief comment and question period from the public, if time allows. And then the public can also enter comments through the chat box below the webcast viewer or via email to primarycare@nas.edu. So now I want to turn the meeting over to Bob to discuss the remainder, some reminders for today's meeting.
Thank you, Linda. I want to note that this is an open on-the-record session, even though we're doing it virtually. I'd also like to remind everyone that this is an information gathering session to inform the committee's work. The committee is in the process of assembling materials for the study that will examine and discuss in the course of making its findings, conclusions, and eventually its recommendations. Therefore, I ask everyone here today to be extremely mindful of the fact that the committee is just getting started in its work. This is only the second meeting for the group. We've made no conclusions, and that it would be a mistake for anyone to leave here today thinking otherwise. Comments made by individuals, including members of the committee, should not be interpreted as positions of the committee or of the National Academies. In addition, committee members may ask probing questions that may not be indicative of their personal views. The committee will deliberate thoroughly before writing its draft report. Moreover, once the draft report is written, it must go through a rigorous process of review by experts who are anonymous to the committee. The committee then must respond to this review with appropriate revisions that adequately satisfy the National Academy's Report Review Committee and the National Academy of Science President before it is considered an official National Academy's report. The committee's report is expected to be issued in January of 2021. Now, I would like to turn our meeting over to the first of our speakers today, Christine Bechtel, who is co-founder of X4 Health. She's a well-known consumer advocate with expertise in areas ranging from social impact design and movement building to patient and family engagement, health IT, quality measurement, and improvement. And she will be talking, addressing today a very important topic for us. Christine?
Thank you, Bob. Thank you guys for having me today. I am going to share my screen and throw some slides up here. Let me know if you have any trouble seeing them. But I'm very grateful to be here today, not only as a patient advocate, but also is just a big fan of primary care. I love primary care. I'm a big fangirl of Bob Phillips and Becca Etz and Asaf. So thank you guys for having me. I was asked to do this talk around a national program we built and run called The Third Conversation, but that was before COVID happened. And I feel like this is a really profound moment in time for us. So I rebuilt this talk. I'm going to go pretty quickly through what we have learned about primary care from The Third Conversation, but I'd like to use it as an opportunity to focus a little bit more on some big picture thinking around what primary care might look like in the future. And that experience is informed for me, not just by The Third Conversation, but by many years of working in and around some of you in primary care, working on things like the Shared Principles for Primary Care, which I co-chaired with Ted Epperly and Julie Shills, and working on with FMA Health and with PCPCC and with Becca at the Starfield 3 series. So lots of broad perspectives have informed me, and I'm going to move quickly. So I'm going to hope that you guys can capture any questions you have around things that I skip over. I hope that you'll invite me back to cover some of the more moving and inspirational stories that we've seen and heard from The Third Conversation. So we founded this idea of Third Conversation primarily because we felt like the triple aim was missing something. I've spent most of my career thinking about and working on and lobbying for national public policies that will make healthcare better for humans. And in the 25 years or so I've been doing that, we've really predominantly focused on the what and the how, or what we might think of as the structural and the technical. So our fundamental question in creating The Third Conversation, which is a foundation-funded initiative, is really, could the cultural and relational stuff, the who and the why, could that really change healthcare? Maybe change some of the types of solutions we develop and maybe even accelerate those solutions. Couple of disclaimers about Third Conversation. First of all, it's not a panacea. So it's not meant as a replacement for the triple aim or for quality improvement or for all of those great things. It's also not meant for everybody. It is not going to resonate with some of you today, and that's okay. And for those of you who feel moved by this concept, let's talk. It's also not a patient forum. So it's not a patient and family advisory council. It's not a purely patient input forum. It is a real conversation where frontline clinicians are coming together with patients and families to get real and talk about what the healthcare system is like for them, whether they're working in it or receiving care. So I'm going to do the first about 90 seconds of a quick video here. And somebody flag me if you can't hear it once it does.
I'd say 3C is the story of a bunch of people who were concerned that the existing healthcare system, especially our primary care delivery system, isn't working for patients and it's not working for practitioners. And we thought, what would happen if those people actually sat down and had a conversation together?
We realized that the human toll that the system is taking on patients is also having a disproportionate impact on clinicians. And we thought to ourselves, has anybody ever brought these two conversations together? That's why we call it The Third Conversation. We were hearing the conversation at the national level about clinician well-being and burnout. When we began to look deeper, what we learned was really stunning. We started to see that, half of clinicians are screening positive for depression. We learned that almost 10% have suicidal thoughts. These are the individuals who we are asking to heal, and they are having just as hard of a time.
When we were envisioning what this might look like and feel like, I think we expected people to talk about what was wrong. We expected people to talk about what they wanted from the system. I think we were really surprised, though, how therapeutic those conversations would become for both participants. It was really surprising for us.
I think Third Conversation is unique because it's grounded in that purpose and in that empathy, that bi-directional empathy. So I think, unlike other initiatives, Third Conversation is a platform for building community in service of a better system.
So privileged to get to work with some amazing humans. So The backbone of the third conversation are these Spark events. They're 3-hour professionally facilitated events. They're half patients, half frontline clinicians. They are interprofessional. They are primarily primary care. And we ask these patients and these clinicians to think about their own experiences in the system collectively. And then we ask them to unpack them. And we do this based on the ideas and the science around empathy. So if you can unpack those experiences and understand the emotions that drive our actions and the fundamental needs, the human needs that are being met or not being met in the system, then we can begin to operate from a different level within ourselves. So we talk about not brainstorming, but dreamstorming from those places. And we ask them to identify those best of MVP moments and identify the enablers that made those possible. And then from that platform, really think collectively about what a desired future could look like. So a couple themes for you that have emerged in these events. Number one, this is actually really profound. Patients and clinicians want the same things out of healthcare, but we are set up as adversaries in the system in these really subtle and sneaky ways. Think about even just the example of time together. Patients want more time with their clinicians, but clinicians can't give it to them, even though they want it too. Many more examples that we can share with you. The relationship as it is today, confined to these 12-minute office visits dominated by documentation requirements, it's broken. For primary care, you guys, this is a huge red flag. It's not your fault, but it is happening within this larger system and we have to address it. We've learned that just creating simple human connection, not necessarily even the quote doctor-patient relationship, but profound human connection is really impactful and it changes the way people show up in the world. We were at a Ryan White clinic last year, and I'll just give you a brief story about that. We had paired in this conversation, there's a 20-minute segment where an individual patient gets paired with a clinician. And in this case, it was a white doctor, probably mid-50s, paired with a young transgender African-American woman. And when they started out, every part of their body was just closed off from the other. Like arms are crossed, their legs are crossed, their ankles are crossed, you name it. They're leaning way back in their chairs. And within 20 minutes of conversation and connection with each other, the clinician, the physician at the end of the night, he stood up and said, you know, this is why I went to medical school. And I am going to start tomorrow. I'm going to re-engineer my office visit completely to facilitate this kind of human connection 6, 8, 10 times a day, because that is what sustains me. And even though there is a personal cost, I'm going to have to do a lot of documentation later. I'm willing to create these changes in my workflow to facilitate this connection for me and for my patients. So we've learned that there's a lot we can do individually. There's even more we can do collectively. So I want to share with you some insights about what I would call pre-COVID primary care. The system creates a lot of emotion in people. We tend to hear a lot about the negative side, but we also hear about the positive side. When we ask them to talk about and unpack enablers, I've gone through all of the sticky notes. You can see we're a big fan of using sticky notes in these events. It boils down to 3 things that really create a positive experience and better primary care: time together, human connection, and coordination and communication. So we think about the desired future. We ask them to just dreamstorm. Just imagine we've worked together to achieve something beyond our wildest dreams. And I want to tell you that what they've come up with, this is what I hope you guys will think about in your deliberations and in your recommendations. It's big picture stuff. Number one, they both want to change the economics of healthcare. They both recognize, patients and clinicians, that healthcare has really become a business. And we did focus groups last year, and I heard language coming from average patients that I'd never heard before in 20 years of patient advocacy. They were using words in these groups like value-based care and ACOs and Epic, the health IT vendor. And my sense is that clinicians are so angry about working in a system that isn't working for them that it's spilling out onto patients and we're overexposing them to these real challenges that we have. They want to change the economics. 2, they want to reimagine access to care. This has both a cultural dimension, but also kind of a technical or structural dimension. So on the cultural side, thinking differently about the team itself, and we can talk more about this in Q&A, obviously changing the physical access. But this also means, we hear a lot, like people are not understanding, why have we bifurcated mental well-being from physical well-being? How does that even work? And how do we bring community resources and services more into the picture? They define success in a different way. They want it defined in terms of health, not just medical care. This is where I think as a U.S. system, we've really fallen down. And they also talk about working together in a different way. I'm going to come back to that in a minute. But the bottom line is our sense is that relationships are both an end and a means in our system today. They're an end in the fact that they're fulfilling in and of themselves. They help address burnout and professional well-being as well as patient experience, but they're also a means to getting to better care as well. So really important to think about how to centralize that in your deliberations. So here I want to say, first and foremost, my take. Be bold. This is a completely new context that COVID-19 is opening up for us, and this is not the time for business as usual. Second of all, I'm wondering whether primary care practitioners actually should become relationship specialists. When I say that, I don't know of anybody else who can do it this way except primary care. Like, this is an area that only you, primary care practitioners, can compete on. Others can compete in a lot of other areas, but I don't know anybody else who can compete on relationships. I think it's important to recognize the new reality and the current way that patients experience primary care. We have seen major changes pre-COVID just in the last 5 years, let alone since 1996, when the committee originally published, the early IOM report. Today, we have minute clinics, we have plush care, we have concierge service, we have texting apps. All of those, by the way, are cheaper and more accessible than my patient-centered medical home. And to put a finer point on that, so my boyfriend, Mike, God bless his little heart, he has a patient-centered medical home as a primary care doctor. When he goes there, he experiences the usual trials and tribulations, wait times and blah, blah, blah. But it costs him $225 to go to his primary care doctor because he has a high deductible plan like many Americans do. Mostly they refer him out. They don't have labs on site. They don't have x-rays, blah, blah, blah. Or for $200, $25 less, he can go down the street to his minute clinic here. He has no wait time. They give him everything they need. They have a lot of co-located services. Their service is impeccable. And then he leaves with a digital copy of his health information, and it's less expensive. But the thing that is missing from that is relationship. So the very thing, primary care, my sense, has really been disrupted by the advent of these trends, but you can disrupt right back if you focus on relationship. Next question, though, I wonder whether or not all patients really need the kind of primary care that requires relationship. And I would love it if you guys would consider whether or not you really should specialize in treating the entire American population. That is a completely different thing than you're used to considering. I get that. But here's the thing. I think primary care, I can imagine a future where you offer all primary care services just like you do today, but you organize and you design around the people who need relationship most. People where having a relationship with a primary care practitioner could lift them into health and well-being in a way that no other minute clinic or whatever can. So there might be 4 different populations that you could imagine that this could really help if you really specialized in relationship. One would be vulnerable populations who are struggling with known drivers of health, what people call social determinants, but really we know is just housing, food insecurity, and jobs, known drivers of health. Being able to orient and organize around that, if you can make the healthcare system work for these vulnerable populations, it will work for anybody. Chronic and complex needs, acute needs at high risk of becoming chronic or complex, and then what I would describe as tricky patients. So tricky patients, this is Mike, by the way, are those who will benefit from the kind of relationship-based coaching and motivational interviewing, patient activation, getting ready to change, feeling inspired to change, knowing how to change, those things that are greatly enabled by relationship. But handing off some of the people, like me, where I don't probably need a whole lot of primary care in that is relationship centered. I just need like some maintenance meds. I know that's completely different than how you guys are used to thinking about it. But remember that from a patient's perspective, we don't think just about the primary care system. So I could imagine a way that all of the other healthcare providers in our system actually orient as a sentinel system, like a network, so that when they, say my local pharmacist or my minute clinic, when they see that I am at risk as a patient of sliding into one of these categories or whatever the categories are, that's when they intervene and they say, you know what, you need to get back to primary care. Your primary care clinician has an important valued skill set that can really help you. So if everybody orients around primary care, that's different than us trying to be all things. So I just want to push your thinking on that, and also encourage you guys to keep a really broad lens as you're going through these deliberations and understanding from a patient's perspective, health insurance design, the cost of care, public health, those larger systemic issues impact primary care, and you can't not engage. So really being intentional advocates on those issues feels important. Lastly, I want to say it's time for you to get in the foxhole with patients. So let's talk about COVID-19 for a minute here. When I talk about relationships, let me just say, I think also it's not just about relationship in the office, right? It's also about advocacy. And when I think about COVID-19, there is an opportunity here. Right now, somebody said the other day that they felt like this is our Holocaust, and what we have to do is get people to safety. That is absolutely right. And it can't end there, right? So when we think about, during Katrina, we moved people out of the 9th Ward in New Orleans to get them to safety, but we moved them to like other communities. And yes, those communities were dry, but we did not address the root cause of Katrina, which was climate change. That's the moment in time opportunity that I feel like you guys have right now. We have our own disaster in healthcare. Our failure to value primary care and public health is making us wildly vulnerable and blowing our system wide open. And if we don't address the root causes, this isn't going to work. We won't make it. What we know is that healthcare providers are hurting right now, not just because of COVID. They were already experiencing epidemic levels of burnout. We know that patients are hurting. And we know that these two constituencies don't actually have a solid relationship anymore. They haven't for a long time. That's what we have to address. These are the two sides that know the most about what healthcare should look like. They have the most to gain and the most to lose if our system fails, and it will buckle under the weight. So I just want to be really clear to you guys, specifically to this Zoom room full of academics and clinicians. You don't have a single patient on your committee. That is an epic failure. That is antithetical to the profession. You guys have cornered the market on person-centered healthcare, and you don't have a patient when you need to have 5 or 7 patients who can really inform your deliberations. But this committee aside, I want to say that clinicians writ large, you can't do this alone. You can't do it alone, or it would have been done by now. You don't have enough power. You don't know. It's not about what we know. It is not about the what or the how of healthcare. We have to begin to prioritize the who and the why. You don't have enough power to do this alone, and neither do patients, by the way. No one knows that more than the frontline clinician in primary care. That's supposed to be our defining trait. And I would argue to you that the power is actually the relationship itself. If this were true already, we wouldn't be fighting about people working at the top of their licenses. We would be working at the top of our humanity. We wouldn't be fighting over how hard it is to address known drivers of health, like food insecurity or housing or jobs, like, of course we would be caring for people's health and not just their medical needs. We would, of course, change the economics of a very broken marketplace. We would get to the root causes. But it is time to get in that foxhole together and to fight our way out of this. We have to stop screwing around. We have to recognize that the power is really in the relationship, and primary care is in a unique position to act and to re-engineer humanity back into our system as the defining trait. So I want to leave you with this, and this is going to make me very emotional, but this is a card that we put together as patients just to show our healthcare providers that we are here, we are staying home for you, we are here for you, and we are very grateful for all that you do. So I hope that we will do this together.
Christine, thank you so much. We have time now for the committee to ask questions. I'm going to kick it off. I'm going to ask actually about something that you used during your presentation, but you didn't talk about because I think you could help us. Thanks to Chris Kohler, Don Berwick admonished us to make sure that we used metaphors to help explain the problems and the potential solutions that we were framing, that it was really critical for our recommendations to be heard. What metaphors, and I think you talked about power of relationship, but what metaphors do you think we should be leaning on very hard in our report?
You know, Bob, I got to tell you, I am the worst at metaphors. So tough question for me to answer because I don't think that way. But what I would say is the idea of the opportunity that we have post-COVID to regroup together, to address those root causes, to think differently, not tinkering around the edges, but really valuing and prioritizing the who and why of healthcare. Like, that's the takeaway here, and you got to do it with patients. Like, if you take anything away, that's what it is. And this idea that you can actually organize primary care differently than we've been thinking of and doing for decades, that's huge. And that's what I'm asking you to consider.
Thank you. Are there other questions from the committee? I don't know that anybody raised their hand, but...
Chris Kohler had a question.
Oh.
Thanks, Bob.
Chris,
and hi, Chris.
Yeah.
Thanks, Bob, and hi, Christine. It's Chris Kohler.
Hi, Chris.
Hey, and thanks for a speed race provocation. Mission accomplished. You in this emphasis on you have this emphasis on relationships, but you also talk about kind of this fundamental failure to value primary care in public health. This is kind of a leading question, but I'm really serious. Do you see another way to express value besides money?
Yeah.
Is money the fundamental, the precursor? It's not the only, but is it the precursor, or is the starting place a process like what you're talking about, or a training mechanism? Kind of what's the order of battle to have a system they have a primary care system that is more relationship oriented in a society that values primary care and public health more? Thanks.
Yeah, thanks, Chris. And big fan of all of your work around investment in primary care. I would say that the starting point is health creation. And that does take us to a system that is organized and financed differently, but finance isn't first. But if we're thinking about health creation and human-centeredness, I think we make decisions in a different way. I think we create value around health that is fundamentally different than what we do now, which is we try to save money and create financial value on medical care and only medical costs. But if we were able to orient around what does it take to address known drivers of health, that seems so simple. Like, I almost feel embarrassed to say that out loud at a cocktail party, because of course we would address known drivers of health. We're health professionals, right? But that's not actually how I believe the system is built. So I think the biggest opportunity to create value is around creating health and doing it in human-centered ways. Good question.
Next, we have a question from Susan Fisher-Owens.
Special populations whom you thought would be ideal to target for primary care. I'm wondering if you have modalities that you can share with us about how to identify these patients without labeling them.
So I think I missed the first part because they were a little late in getting you off mute, but I think you were asking about some of the special populations. How do you not? So I actually would say, again, come back to the relationship. I think clinicians know who they are. I remember Farzad Mostashari in the early days of Aledade, which is an ACO, trying to help people use their health IT systems to identify, different categories and populations of patients based on the data in their record. But what he did first was sat down with the lead clinician, the physician at the practice, and said, you tell me, make a list, tell me who's at risk in these categories. And she nailed like 97% of it without even using the electronic health record. When clinicians are in relationship with their patients, I think they know who needs to be supported and lifted into health creation. And of course, I'm a big fan of health data. Most of you who know me know that. So use health data as a buttressing. But when we're in relationship, it removes our ability to be othering people, to label them and put them, objectify them in that way. When we're in relationship with them in a human connected way, we don't actually do that. That's my belief.
Susan, I saw your hand go back up. Did you have a follow-up question?
Yes, thank you. I was going to say, absolutely agree with you within the relationship, but it seemed as with looking at these target populations, there are some that we would want to get to come into primary care so we could establish that relationship. And how do we identify them before that relationship is already established?
Oh, thank you. Yep, absolutely. So I was trying to explain this idea of it's a flip of our current model, which I think it's hard to understand. But this idea that, so first of all, the burden shouldn't be on primary care to do everything, like recognize and get the patients into the office. If we imagine the system as patients experience it, which is not primary care, secondary care, and tertiary care, there's like just healthcare, right? And we understand all the places they seek care, then those the places where they do seek care can be the sentinel and can actually reinforce and refer and connect back to primary care as a central asset in the community. So I would say it's not. So when I look at, I use my boyfriend for a reason. That guy is so hard to get to want to be healthy. Like, he is your classic, totally unhealthy and just a pain in the butt patient, right? I love him, but oh my God. But people know in this community, as I said, the Minute Clinic, the pharmacist, there are lots of other indicators that actually he would benefit. He falls into that fourth category. Or whatever. I'm just using him as a personal example. So the burden isn't only on primary care. The burden is on the community of healthcare providers writ large to connect the right humans back who would really benefit from the skill set and the relationship that primary care provides.
Hi, Bob and Linda. We have about 2 minutes left in this panel, and I've got 7 people queued up for questions. So should we just start with the first 1 or 2 and then unfortunately have to move on? Or should we see?
Yeah, and I would ask the folks who have questions they don't get to, let's save them for the end of the day or bring them up in the break.
And I'm going to, while you guys are asking, I'm just going to flip back and forth between 2 slides. So if you got some questions, reach out to me.
Great. And so for Shauna Hudson was next, and then Brenda was after that.
Hi, Christine. Thanks so much for a very provocative and interesting perspective. I wanted to ask you, because one of the things that we've been sort of thinking about and we'll be grappling with as a committee is really the definition of primary care. And from what I got from your talk was really sort of this oppositional perspective in terms of Minute Clinic versus sort of what we think of as traditional primary care, and what you talked about in terms of relationships. So part one of the question is really sort of Is my sort of interpretation of what you said, what you were meaning? And then secondly, sort of thinking about as we retool this definition of primary care and sort of think about sort of embracing versus really sort of a specialization in terms of relationships, how do you see that sort of unfolding, and what would your perspective be in terms of voicing issues for patients?
Yeah, so I heard two questions. The second answer is, I don't know all the things. I think if I knew all the answers that, around how to make this work, I would have been advocating for it for a longer time. What I do think is that the way we make decisions has to change. It has to become more driven and supported by bidirectional empathy, a deeper understanding of the human needs at play in the system that drive our actions. I think it has to be driven collectively by patients and clinicians. It can't just be the clinicians anymore. It has been that way for too long. It's why we are where we are. So I think if we make decisions differently, there is, a lot of evidence around sort of the emergence of group intelligence. And there's a new way of thinking when we get diverse perspectives into the room. And that, I think, is what we need. So if we can create those things, number one. Number two, I think we have to think about how do we value and prioritize relationship in the system? How do we make it possible in the constraints of the system we have, or blowing those constraints wide open to change the economics of healthcare, to give us more time together, more ability to create connection, more training for you guys on how do you actually do that from your front lines to your front desk, relationship building, creation, bidirectional empathy, and human connection. If that begins to permeate, I think that's an excellent starting point. And I feel like I missed the first part of your question, but I'll email you.
Sounds good. Thanks.
And Christine, would you mind if folks who didn't get to ask their questions today were able to email them to you?
Yeah, absolutely. I flashed my email. It's on the last. It's on the last slide. You can tweet at me, whatever you want to do.
Thank you.
Yeah. Oh, policymakers, Ben, good question. So that's what I want to do next. I think that we can do a version of the third conversation that includes policymakers and what you're describing as the medical industrial complex. We have to engage our decision makers as humans. We just finished doing 10 interviews with health system leaders, and people don't engage them as human beings. We go in and we point fingers and we fight about it, and we're just been buried by an avalanche. And if our next move, I swear to God, is fighting about what rocks go where instead of linking arms and helping understand and rebuild together, I don't know what I'm going to do with myself. So I think there's a different way forward that comes from a different place. That's why the third conversation talks about reinventing first the patient-clinician relationship, but then healthcare from the inside out, which is inside of ourselves, but also from within the system based on, our collective human experiences and knowing what we need. So thank you guys so much for the opportunity to talk today. Thank you, Ben.
Christine, thank you so much. Our next panel is on policy change in primary care, challenges, realities, and opportunities. Our first speaker today is Dr. Kara Odom Walker. Dr. Walker is Secretary of the Delaware Department of Health and Social Services, and in fact, after her presentation is going to take a break to go do a briefing, and then we'll come back to answer questions. She currently oversees one of the largest departments in Delaware's government with an annual budget of $2 billion. She previously worked as a Deputy Chief Science Officer at the Patient-Centered Outcomes Research Institute, or PCORI. She's a board-certified and practicing family physician, and was previously a faculty member of Family and Community Medicine at University of California, San Francisco. Our second speaker today will be Dr. Mai Pham. Dr. Pham is currently Vice President of Provider Alignment Solutions at Anthem Incorporated, where she's responsible for developing and refining Anthem's provider payment models. She's really focused on patient-centered care and reimbursement for physicians for value-based rather than volume-based performance. Before going to Anthem, she was the founding official at the Center for Medicare and Medicaid Innovation, where she served as Chief Innovation Officer and was responsible for implementation of the alternative payment model. She also was one of the early developers of the pioneer and next generation ACO models, the Comprehensive Primary Care Initiative, And before that was co-director of research at the Center for Studying Health Systems Change and Mathematica. She's a general internist who practiced for several years at Safety Net Clinics in Washington, D.C. And our third panelist today is Dr. Bob Berenson, who is an Institute Fellow at the Urban Institute, serving in senior positions prior to that in 2 presidential administrations. The first, where he was in charge of Medicare payment policy and managed care contracting at what is now CMMS, and in the Carter administration, where he served as an assistant director of the domestic policy staff. A decade ago, he served on the Medicare Payment Advisory Commission, or MedPAC, and then more recently was a founding member of the Physician-Focused Payment Model Technical Advisory Committee, or PTAC. He's a board-certified internist who practiced for 12 years in Washington, D.C. in a group practice. And I want to thank you all for being our panel today. Kara, I'm going to turn it over to you.
Thank you, and thank you for displaying my slides. This is a starting point, but we wanted to share a little bit about our path and then also provide some thoughts about recommendations of where we should land. Next slide. Pre-COVID-19, Delaware was on a path to move to healthcare transformation and decrease healthcare costs. They really focus on these core strategies you see on the slide, really focusing on moving to pay for value, having additional data, but also thinking about where the work could focus on workforce, team-based care, and population health management. We also were in a place where we had, there we go, the next slide. Along with the state budget crisis that was pretty massive when I started 3 years ago, and data from CMS that showed we were the 3rd highest per capita in healthcare costs, we had a backdrop to have a focused conversation around Delaware's microcosm of issues, what made us high and what makes us stand out. And this data is now quite outdated, but we don't have updates from, it was a release in 2017. Next slide. We also started to have questions in our state about why Delaware healthcare costs were so high. And you could see in all categories of spending, Delaware was higher than the national average. That blue bar made people say, well, it's not just us, don't point the finger in one place. Maybe it's that we have slightly higher hospital costs, but truly we're high in all categories. But we didn't have good data on primary care at all. Next slide. So we started to look a little bit deeper, and with emerging information from many of you on the panel, we knew that a robust healthcare system should focus on spending around 12 to 15% of total costs in primary care. In the US, the average is about 6%, and based on the data that we had, we estimated Delaware was somewhere between 3 and 4%. Not exactly sure why. Maybe it's because we have a lot of small independent practices with little or no leverage with the insurance companies. But certainly when you looked at the commercial pay, it was significantly lower than Medicare and Medicaid. And our hospital-owned primary care physicians were getting paid 50 to 70% more than independent physician practices for the same services. This really was an alert, and the primary care community came out loudly as we were talking about total healthcare costs and said, what about us? Make sure you're focusing on primary care. Next slide. So this is a picture of one of the hearings where primary care docs, including the one featured here, Dr. James Gill, who's a health services researcher and a very vocal primary care physician that's part of an ACO in our state, wanted to make sure that people heard about primary care, heard about its implications on total cost of care, and they came out in force. And I can't tell you how important it was to have the voice of the physicians at the table, sharing their experiences, sharing their challenges, and really focusing on new efforts, but learning from others across the country about how to focus on measurement, how to focus on data. Next slide. We also had our governor focused again on establishing a healthcare spending benchmark. This is our website where you can look at some of the meeting and deliberations and presentations if you're interested. But through executive order, he decided to set similar healthcare spending benchmarks that was paired with a health quality benchmark. And because of the conversations around primary care, there was also a quality indicator that would be reported annually that really focused on indicators of primary care. And they focused on things like wellness and prevention, but also preventable emergency department use. And I think it was essential to have that conversation with primary care and focus on data and evidence. Next slide. So the healthcare benchmark was moving forward through executive order. In parallel, legislators took hold of this idea to support primary care. Senate Bill 227 was established to create 3 key areas of focus. One is creating a primary care reform collaborative that facilitated ongoing conversations around primary care. The second was requiring all health insurance providers to report data to our Health Information Exchange and the healthcare claims database through the Delaware Health Information Network to measure costs, measure quality. And then the third was requiring a rate increase to the level of Medicare for the next 3 years for all primary care services to elevate and create a floor of payment. Next slide. So we had a year-long set of conversations around primary care and the primary care collaborative meetings. And what they found is they needed more information. The initial collaborative was intended to be a public gathering with 3 members established. There was a member from the House, a member from the Senate, and the Healthcare Commission chair. And I think what we found is that you really needed kind of a well-rounded set of perspectives. And so Senate Bill 116 allowed us to add people to this collaborative, add people to the conversation, and make sure that we were focused on what primary care investment could look like and should look like. Next slide. So that's just a brief summary of how we got to where we are now, which is, I think, an essential part of building recommendations around primary care spend and moving to this new vision of what primary care could and should be. And the first is, I think it's really important to create core fundamental elements of a vision for primary care spend, including definitions, because we spent probably 6 to 8 months just talking about the definition of primary care and still have not landed on a solid place for Delaware. If that was something, again, that could be a key recommendation, I think that's critically important. It would allow a much more faster movement around state-based initiatives. The second is by focusing on this essential foundation of primary care, the investments could be something that's a menu of options that's consistent with evidence, but also consistent with political goodwill. Most legislators want to focus on primary care. They believe in it. They love their primary care docs. And so that's an easy win conversation. But I think the dialogue and the debate around the investments is a challenge, and one that could be better suited if we had a core set of recommendations. I also think it's important to create a definition for the measurement of primary care spend and a standard. And there are ones out there, but again, it's harder for small states to leverage some of the existing work because it's based on Medicare and we don't have the size. So I think that's a really important part. And if it's coordinated by a national entity, that could also really help with offsetting state pressures to set up large infrastructures for staffing, expertise, and really create sustainability and a less politicized decision-making process for how you invest in this measurement. I think then states could really build off of this national standard with specific strategies that could address local issues. For us, for example, that's really making sure that local independent small practices have the support they need. So investments in that space look differently than in large practices or large ACOs. We are pushing in a separate parallel track for ACOs and other kinds of strategies, but I think the ones and twosies is still going to be the way that primary care is delivered for a very long time in our state. Next slide. Additionally, it's really important, and what we've also spent a lot of time on is what the milestone should be, and whether it's 12% or 10% or 15%, I don't know that it matters, but I do think setting a goal is important for states to be able to compare and contrast where they've made progress and where they haven't. And then they could figure out independently whether that occurs through a 1% increase or within a time frame or whichever is faster. I think having that flexibility could be valuable. But thinking about how to create this definition of medical spend, and maybe even, again, we've used the CMS data release that only comes out intermittently. The last data release that we had was from 2014. If that could be an annual exercise, that could be incredibly valuable for states to be able to track categories of spend and overall spend. And then they could monitor and measure growth over time. That primary care benchmark could be something that's coordinated nationally, but the data, the tight measurement issues, having clean data, having data that's less debatable, has been incredibly valuable for us as we talked about not only total spend, but also facilitated these conversations around primary care spend. And that framework is one that, again, there are sort of core elements, but there's a lot of debate on whose pocket this money is coming from. So I think there also needs to be some core recommendations around, do you need some other cap on measurement so that you have a total number, and states who have successfully done this have other levers like monitoring and regulating hospital budgets and their increases, or ACO budgets and their increases, or a benchmark and their increases. Again, I think it's important to have that as a paired conversation in order to successfully be able to refocus on primary care. Otherwise, you're just exploding the balloon and with no limit in sight. And that's the biggest struggle politically that we've had in Delaware. But I'm happy to share our experiences and my thoughts about how to continue to move forward in these important areas. We are still learning. Our Office of Value-Based Healthcare Delivery is now up and running. We have contracted with a vendor who will calculate total spend and the primary care spend in our state. So this will be a year of a lot of learning for us, a lot of work around setting definitions and variables and measurement challenges, and really excited to continue to share that lesson and what we're learning there. Thank you. Next slide. Let's end.
So we'll take questions at the end of the whole panel. So, Dr. Pham,
thanks,
are you ready to go next? Yeah.
Yeah. Let me, so those are hard acts to follow, but let me try to take a step back and come at this from a slightly different perspective, a slightly different question, which was the one I asked myself about whether we've actually saved primary care since the 1996 report. I think we know the short answer, or maybe I shouldn't assume that we would all agree on what the short answer is, but just taking you through how I approach thinking about it. And, I think as has been implied by both the first two speakers, it is important to acknowledge that something has happened in our march to the goalposts in the 1996 report. The landscape has changed dramatically. This is not necessarily about the goalposts having moved, but rather all kinds of headwinds and crosswinds and ground shifting under our feet. And as you go about your work, I really hope that you make some explicit acknowledgments, concrete, quantitative acknowledgments about the shifting landscape to assess whether those goalposts need to be made even more proximal, I guess, or more tactical in order to make progress. A lot of this will seem familiar, but I think that it's worth calling out that in the time since the report, we've seen a market shift in market consolidation, both vertically and horizontally. And that means that there are many health systems now having absorbed a great number of independent medical groups. And in many cases, some of the higher performing medical groups. This has all kinds of ripple effects in the broader healthcare delivery system and in the way that patients and consumers experience healthcare, as well as the ability of policymakers to influence those market dynamics. We've seen increasing growth of venture capital investments flowing into primary care, as well as into other healthcare ventures. What the good and the bad of this on net will be remains to be seen, but it's undeniable that it has affected the dynamics between different healthcare actors, and it has affected how healthcare gets presented to consumers in many cases and to patients. There are now many more multi-state entities in the healthcare ecosystem that, again, changes the underlying relationships between payers and providers, between providers and patients, between policymakers and everybody else. Some of these multi-state entities are incumbents who are expanding their reach. Some of them are disruptors. Whether or not the disruptors will actually get a strong enough foothold to affect the underlying dynamics remains to be seen. I think that open question mark is an opportunity for policymakers to step in and send a clear signal one way or the other about whether incumbents or disruptors will be favored, depending on whether the assessment is that a particular type of disruptor is going to be healthy for the system. But nevertheless, all of this is roiling out there. We're also experiencing really significant generational and cultural changes among clinicians themselves, what they expect from their careers, what they expect from their work-life balance, what they expect in terms of their relationships with patients, their relationship with technology, and the arc of their career, how long they will be in direct clinical care. These changes, I'll come back to later, I think are far outpacing whatever evolution is happening in our training pipeline. And I think that that's a problem. We're seeing tremendous shifts in consumer, purchaser, patient expectations. And I want to emphasize here that these are not, but while there are certainly broad trends, I think what's really important to recognize here is just how segmented and fragmented these expectations and sort of cultural memes about healthcare have become. And this is going to be a challenge, I think, for the committee, because it implies that a one-size-fits-all approach is clearly not going to work. And designing a system that is nimble enough to offer the kinds of multimodality, multi-level options in care delivery and primary care will be a real challenge. That's going to be a challenge to articulate that vision in a way that is cohesive and inspiring, but still realistic. And then last but not least, I hope that we were all knocked back on our heels when the JAMA report came out last September, documenting a plateauing of life expectancy and increasing mortality for Americans in midlife. I think it really begs the question, what are we doing here? And how close to goal are we really if primary care is intended to be the first line of defense in health or health care at the very least, and ideally health as well. And this is the outcome that we're looking at in this day and age. And then last but not least, I think it's important to acknowledge that COVID-19 is causing some severe and acute clinical and financial stresses on primary care. The long-term effects, we will have to all wait and see. I think others have spoken, or others will speak a lot more about the role and prominence of telehealth and other digital tools, and how the expectations for those services will have shifted, perhaps permanently, throughout this crisis. But what I'm really focused about, in part because of my day job responsibilities, but also because I always have this eye toward the long-term primary care infrastructure, is I'm very concerned about the actual viability of independent practice and the actual risk of insolvency for meaningful segments of the primary care delivery system. And then questions about primary care's role in public health, as was mentioned earlier, I think we as a country are going to have to grapple with for real. I won't linger here because I think we're all very painfully familiar with how suboptimal current information technology is in many ways in terms of actually supporting primary care as it's meant to be practiced. It offers many opportunities, but also lots and lots of challenges that we have not yet managed to address. Landscape has changed because we spent the last 10 years experimenting with value-based care. And, what we tried to do in this movement was to ignite delivery system transformation, to make it more team-based, to offer incentives for people to focus on population health, to be proactive, and to at least attempt to engage the entire medical neighborhood rather than leaving it purely on the shoulders of primary care alone. And we've tried to marry that with payment reform, even though the tools that we have to work with there are essentially just kind of reordered, reconfigured ingredients we're very familiar with. As Jamie Robinson famously said, the 3 worst ways to pay physicians are capitation, salary, and fee for service. And so that's what we have. It's a question of how we deploy them and how we price them. So I think we would all acknowledge that we're not quite there yet. In terms of having payment that is truly prospective, truly multi-payer, consistent, rationally risk-adjusted, married with quality guardrails that are meaningful as opposed to numerous, and that actually take into account patients' experiences and perspectives. Measuring primary care spending, that lots of folks will touch on that with you, and so I won't delve in there except to say, obviously, there's a lot of work to be done there, and I think we need to be very crisp and err on the side of simplicity in order to build momentum with an eye toward refining that definition further down the road, because holding up measurement and transparency into where any such metric is will do more harm than having a metric that is somewhat less than optimal. And then lastly, and this is a real pain point for me because of my personal quest over the past 20 years, is that we've made a little bit of progress in repricing primary care, but not enough to have it really change the experience in the marketplace. Change the experience of primary care providers feeling valued, change the experience of new medical graduates choosing primary care. And frankly, when we talk about increasing primary care spend, there are really only 3 components, right, that will help you move that metric. Either you increase the prices, or you increase the utilization of units of primary care, or you increase the categories of things that you call primary care spending. So if we can't move the prices much more dramatically than we have, I think we're going to hit a wall on that overarching metric. We've seen a growing commitment to addressing social drivers. Again, I won't linger here just because other folks are going to talk about this or have talked about it and will be much more eloquent. But I do think that it presents a tremendous opportunity for primary care. And it's not clear yet that the field has really stepped up. So how have we adapted? Again, this is about, I think, internal reflection about what is within our control, but also asking ourselves the hard questions about what arguments, what battles, what collaborations, what engagements have we actually avoided or skirted or diluted in the years since the report that we really need to double down on now. We need to, do better than this polar bear has. That coat needs to start turning brown. So when I look back at the report, my high-level assessment is that in terms of the definition of primary care, it still does hold in a very fundamental way, but it's being applied in the real world in such an uneven manner that it's really robbed of its meaning. Primary care itself as a field lacks a single cohesive voice. And that's very hard for me to say as someone who has collaborated with many of the leaders in the field. But I also experience the fractiousness when it comes to political decision-making and prioritization. And that hurts primary care because those competing voices trying to get policy attention and resources in the marketplace are much more cohesive. There's very little public understanding of or demand for what we might conceive of as advanced primary care. And yet, as I think, we've already heard, many patients know it when they feel it. Once you have a primary care provider, your loyalty to that provider is extreme. And that carries through all the life stages as long as insurance coverage applies, and you have that option. And I think that that's a tremendous foundation to build on. But we have some challenges because more and more young people do not have a primary care provider that they identify with. And until we get that hook into them, they won't experience or act on that loyalty. So how would I grade policy making and the response of the marketplace in terms of getting to goal or getting to the goals as outlined in the 96 report? I think in terms of insurance coverage and availability of primary care, this is out of 5 stars. It's very gross, and for sure you will take issue with it. And perhaps when I filled this out, I was having a particularly dark day. But I would say we've made some progress, particularly with the Affordable Care Act and with Medicaid expansion. But we still have some ways to go. Still double-digit millions of Americans without health insurance. Payment methods that support primary care functions with value-based care and kind of a meaningful plurality of American providers now in alternative payment models. I would say we've made meaningful progress, but again, not necessarily to the depth and for sure not to the breadth where it may permanently shift how well primary care providers can execute on those core functions. Higher prices, we've done less well there. Interdisciplinary teams, at least this has become an expectation, even if the execution is uneven and the resources are not always available. At least the expectation is there, and it's beginning to creep into training venues, which gives us hope about what future generations of providers will approach the work with. Embedding primary care and care for underserved populations, I do think we've made meaningful progress here, but again, only to the extent that we can marry that with insurance coverage and primary care supply. I don't think we've made much progress on explicit collaboration with public health, as I think we're all experiencing currently. I think that there has been some early movement on integration with behavioral health, collaborative care payments, increasing accessibility to behavioral health specialists through digital and other asynchronous or remote means helps with that. Models like ECHO help with that, but we are certainly nowhere near the point where it is a given that primary care and behavioral health care can be integrated in any given point of care. No movement on integration with long-term care. And in terms of uniform and meaningful performance metrics, there are pockets of collaboration and alignment. Having CMS taking a leadership role certainly helps with that, but there's still a tremendous degree of fragmentation and frustration as a result in the field. We've made some progress on the workforce, but I cannot say with confidence that the institutions training our future clinicians have really anticipated what care delivery of the future looks like and are planning for that. Geographic maldistribution is only heightening, and we have the macroeconomic trends and the macro mortality trends to illustrate some of that. Scope of practice constraints are still a significant political barrier. And retraining, MOC, has certainly become more prevalent and expected, but remains contentious. So in conclusion, I think much of that report remains relevant, but the changes in our macro environment require that this committee really take a hard look at updating the goals and strategies for primary care. And primary care itself as a field is coming to a reckoning. There's been a lot of conversation and a lot of great work, but at the end of the day, some of the hardest conversations and some of the hardest work we have intentionally set aside for another day. And I don't know that we're going to get that other day. So my question for the committee is, will the next report inspire true transformation? Thanks.
Dr. Pham, thank you so much. Dr. Berenson, are you ready?
I am ready if you can hear me. Yes.
Yes, sir.
Okay, so you're going to also do my slides. I appreciate it. So if we could move on to the next slide, please. So what I'm going to do briefly is consider the changes and expectations of high quality primary care since the 96 report. Even though it's not directly related to policy, these have implications for where we need to focus our policy. And then I'm going to spend a good part of the presentation talking about workforce payment and quality measurement. Next slide. So let's stipulate that relatively more primary care is associated with higher quality and lower costs. There's now a growing body of literature that strongly supports that proposition, so I don't need to argue that here. But the point I want to make is there's also been recent work by Elizabeth Bradley and Lauren Taylor, and beginning to be reinforced and supported by other researchers that finds that health systems that provide what's happening to my slides. That health systems that provide a much broader commitment to providing social services and less on healthcare is associated with higher quality and lower costs, just like primary care is. So my point is that we absolutely need to increase the share of primary care, the share that primary care gets of healthcare dollars, but that might not result in a major absolute increase in remuneration. It's about allocation. And again, there's been reference to Rhode Island. The Delaware is now moving in that direction. It's a redistribution. It's not a dramatic increase in primary care, although I think a modest increase is absolutely necessary. Next slide, please. So primary care is evolving, and here the point I want to make is I took a definition from the 96 report and emphasized that the expectation is that primary care would be accountable for addressing a large majority of personal health care needs. And I think, in fact, that's not the case. It probably wasn't the case then, and it certainly should not be an expectation in any new definition of primary care. As you've heard, current estimates are that primary care represents about 5 to 7% of total commercial insurance. In Medicare, it's even less. In work that I've done with my data, it's only about 2.5% of Medicare spending and even less than 20% of spending in the Medicare physician fee schedule. In short, primary care does not directly address a large majority of personal health care needs, and as discussed next, should not now be expected, and I will argue really doesn't indirectly affect all of that care. Next slide, please. So from 96, the Barbara Starfield 4Cs was prominent as the as sort of the attributes of high quality primary care, which I've repeated there. And what I'm going to argue in the next few slides is that primary care's commitment to the first 3 of these is waning, while the range of coordination responsibilities is growing dramatically, and that a series of other responsibilities increasingly characterize high-quality primary care. And here I'd say there's people mean different things by comprehensiveness. What I'm going to argue is that clinical comprehensiveness is declining, but that practices can provide a comprehensive set of other services, many of which my sort of outlined in the previous presentation. Next slide, please. So there's no time to go through this in any detail. I saw a pre-publication copy of a book by Ken Terry, and one of the chapters was Primary Care on the Ropes. And he has a hypothetical that one of his first, it actually led the chapter on primary care on the ropes. An intern is describing how he, in this case a he, would have been able to manage a patient in the office and not to have them go to the ER and ultimately have unnecessary surgery. And I read this case, and maybe later in the day you'll have a chance to actually read it. The point I'm making here is I don't believe that I think only about 1 out of 10 primary care physicians today would have done what this physician did and managed this patient in the primary care practice rather than just sending them to the ER. Indeed, I suspect this physician is a dinosaur who will soon be extinct. Next slide, please. So what's been happening with referrals? Another sort of source of evidence about what's happening in the comprehensiveness. This study by Barnett, Song, and Landon in the Archives of Internal Medicine demonstrated a doubling in referrals from 1999 to 2009, similar increase for primary care alone. And I've been in touch with one of the authors, and they are continuing this analysis and now find that the referral rate is in the 13 to 16% range in the last few years. So almost a tripling in 15 years. Also, one of the points that I think is important for the committee to keep in mind is that there is a lot of heterogeneity in primary care. In this one study, which is now 2 decades old, there was a referral rate of less than 1%. I don't know who that physician was. He's some kind of super physician, to just about 70% of patients referred in a year. So there is great heterogeneity. Next slide, please. And there have been, the authors of that study, as well as some other papers, have suggested reasons for the rise in these referrals, including knowledge gaps, time pressures, defensive medicine, but in this 15-year period, malpractice has not been much of a problem. Patient preferences. What doesn't get a lot of attention is that we have moved from what was then a pretty dominant method of gatekeepers and HMOs, where physicians had financial incentives to not refer, to more of a PPO platform where there generally are no penalties. And then finally, the specialty orientation of medical school and graduate medical education. I raise these to just discuss, for purposes of what do we do in policy, is to try to address some of these problems. Some of them might be immutable, like the knowledge gaps for specific disease entities. Next slide, please. So first contact and continuity, I would argue, has also declined significantly. There are various factors that lead primary care practitioners to no longer see their patients in inpatient or post-acute care facilities, again with substantial variation. Again, in data that I have been working with, family practice physicians receive only 12.9% of their revenues from inpatient or observation stay visits, whereas internists, it was 40.6%. But I suspect, and here I don't have the data, that there's a bimodal curve for internists, that many also don't go to the hospital and see their patients. And then there are some internists who predominantly do hospital-based medicine. And that would probably include some hospitalists. But my overall point is that primary care physicians don't follow their patients into the hospital. It's just become sort of accepted. And another point I would make, and this I find correctable and should be correctable, and in my primary care practice, it was an essential responsibility of our practice to be involved with care of patients in the emergency room. We often called ahead to tell the ER doc that the patient was coming, what we knew about them, why they were coming. From what I hear anecdotally, that rarely happens anymore. And indeed, communicating with the ER is not an expectation of the patient-centered medical home. And as a result, I think there's many unnecessary admissions because there's no comfortable home that the ER doc can send the patient to, where they know that somebody's on the other end who will care for them and knows about what happened in the ER. Next, please. A recent study talked about outcomes related to primary care and found that the receipt of primary care was associated with more high-value care, somewhat more low-value care, and better respondent access and experience. That's generally a pretty positive finding. It did worse than specialty care for heart failure and pulmonary disease, which some would consider sort of core activities that a primary care physician should be expert in. And interestingly, about a quarter of the adults report not even having a primary care practice, and 2/3 of these did have private insurance. So it is consistent with the earlier discussion that that patients often get their care outside of their primary care outside of primary care practices. Next, please. A commentary on these findings, Alan Gorel, who's a Harvard professor, internist, and sort of the author of sort of the basic Bible of primary care, clinical Bible. To be sure, the excellent patient experience performance is likely to reflect considerable physician effort, but these results suggest primary care physicians are spending most of their time arranging prevention, performing screening, and offering counseling, while their physician-level diagnostic and management skills, could you go back, please? Or go to where I'm directing. Management skills seem to be unused and might be atrophying. I share this concern, but I think he seriously discounts the many other things that primary care practitioners are doing now beyond prevention, screening, and counseling. In short, clinical comprehensiveness is in decline, but comprehensiveness on a range of other activities is now a foundation of primary care. Next slide. And this supports the case that primary care physicians see more complex patients, primary care practices. I don't want to be so physician-centric. Primary care practices see more complex patients as defined by the number of diagnoses and the number of medications. So the point is here that it is not just prevention. It is not just screening and counseling, that there is a major coordination role that primary care practices are providing. Next, please. So we clearly don't have time to go through all of this. This is my set of expectations that we now have for quality primary care practices. And I just, for purposes of this presentation, I just want to talk about a couple of them. The first one is making accurate diagnoses and referring when it's outside of their expertise. And I'd refer to the IOM Improving Diagnosis in Healthcare. I was a panel member. We still have an ongoing significant problem of misdiagnosis and failure to diagnose. And it seems to me all physicians need to improve in this area, including primary care. I think, in fact, this is the third bullet, primary care physicians actually are looked to manage a number of high prevalence, what I'd call primary care-based chronic conditions. Hypertension, diabetes, dementia should be managed in a primary care practice. And here, I would argue that they should be expert at caring for patients with affective disorders, including depression, anxiety, even though many of them don't have time or interest in doing this at this moment. Other activities, other expectations. One that I would also say doesn't get much attention is to be responsible for chronic care drug management of patients with multiple chronic conditions who then are on 10 or 12 or 15 drugs. Primary care physicians should be as expert as anybody in dealing with drug complications, drug symptoms that turn out to be related to drug interactions, etc. My point here is to not go through all of these and make a case as to why these are core activities, but simply say that the primary care practice has changed dramatically, I would argue, since 1996, when it was focused mostly on more straightforward clinical problems. lots of these activities are about coordination and complexity, and not about comprehensiveness and continuity. Next, please. So now when I get to the policy implications of all of this, just briefly to say that in the Affordable Care Act, there was a healthcare workforce commission established. It never got an appropriation. It never functioned. The people got appointed to it, got their diplomas from it, and they never had a meeting. We need it as much now, if not more now, than even when this passed 10 years ago. And this is just a summary of what its expectations were. Next slide, please. Because the workforce data shows that there are some significant problems that need to be addressed. We have a lower patient practicing physician to population ratio than other countries. We're near the bottom in the OECD data. We have too many specialists to primary care in the U.S. It's 2 to 1 in most countries. It's approaching 1 to 1. I'm sorry, it's approaching 2 to 1 in the U.S. It's about 1 to 1 in other OECD countries, although there are some definitional issues here. The fourth slide, between 2005 and 2015, the number of jobs for primary care physicians grew 8%, while jobs for specialists grew 48%, with even including PA and nurse practitioner growth. Primary care practitioner jobs grew only 17% in that decade. So we still have a maldistribution, and it's increasing, not decreasing. And indeed, by one account, I realized I didn't remember who it was. I now realize it was a recent MedPAC report. There are only 2,500 geriatricians to care for nearly 70 million Medicare beneficiaries. So there is remaining and increasing a workforce problem. Next. And here are some of the issues that have been identified, and I'm not going to go through them. It is what this commission should deal with, and if we don't have a commission, it's what other policy levers need to be used to try to address at least some of these, such as the relatively low remuneration, unnecessary hassles of practice that could be dramatically improved, et cetera. Next slide. So just a few points about payment. I spend most of my time thinking about payment. I'm a contrarian about volume to value. In Europe, fee-for-service is generally referred to as pay for activity. It's not called pay for volume. It's less pejorative. Many European countries actually paid hospitals on budgets and found that the hospitals took the money and didn't provide a lot of services, so they moved to DRGs because they wanted to reward activity. One could make the same case that some fee-for-service payment is actually desirable, and I would argue that all payment models are designed and implemented to provide more or less value, but they all have inherent strengths and weaknesses. But improvements to the Medicare physician fee schedule, mostly with new codes, the Care Transition Code, the Chronic Care Management Code, have improved value more than APMs in recent years. It should not be ignored as a source of value, the physician fee schedule. And indeed, some of the most promising primary care payment models are hybrids of fee-for-service and per person per month case management payments, for example, CPC Plus. However, Bob, having said that, a lot of the...
Bob, I'm sorry to interrupt. We only have about a minute left. I just wanted to give you a time check.
I have less than a minute to go.
Okay.
Many of the activities that are inherent in current conceptions of primary care are not well supported with fee schedule payments, especially what we all anticipate to be a broad expansion of non-face-to-face communication. I can deal with that in Q's and A's if there's any time. And finally, it is time to revisit resource base as the basis for relative values. Fee levels should also attempt to achieve policy objectives, one of which should be to encourage more time with patients in person or otherwise. And with that, I will not talk about quality measurement other than to say I think the future is in quality improvement activities not quality measurement for consumer choice, but quality improvement to actually improve care. And with that, I will stop.
Dr. Berenson, thanks so much. Tracy tells me there are several people with their hands up and that I just happen to be first. I'm not taking the prerogative of the chair. But my question relates to your closing statement and one that Mai said earlier in hers, and that is this issue of measurement. So I would give it to both you and Mai. Mai, you said there are sufficient measures. Bob, I think most of your talk outlined that we're not measuring what really matters. If the first of the 3 C's are going down, because they are really not measured in any way currently. And I just wonder if both of you could speak to this issue of measurement since it's an intensive focus for us.
Yeah, so do you want to, I'm happy to start, Bob. I don't think Bob and I disagree. I think I tried to make the point that we are not measuring the things that are most meaningful. There are some practical hurdles to doing that. Collecting PROMs is resource intensive. It is not something that clinicians enjoy doing, even though they keep asking for those metrics. And at the same time, there also at a macro level tends to be a race to the lowest common denominator, by which I mean that while everyone would like all payers and every measurement organization that is trying to collect the data to be as aligned as possible, that tends to not favor the organizations pushing the envelope and trying to build the most evolved measurement system that is more streamlined, that is burdensome, that is more meaningful. That tends to not work well with alignment. So you kind of have to pick which would you rather have, payers who are pushing that or everyone aligned on a lower common denominator.
I would make a separate kind of a point, which is my concern is less with performance measurement than what it's being used for. I think we now have about 15 years experience with pay for performance across many countries, including the U.S., and it actually doesn't work very well. And especially for health professionals, it probably compromises intrinsic motivation and converts professionals into people who respond to narrow financial incentives for a particular set of measures. So I don't think MIPS or related approaches to try to reward physicians for what payers think they should be doing is a successful policy strategy. There's some role for using measures for public reporting. But again, we haven't figured out what the core measure set might be that patients would use for that. I think patient experience measures is probably where that should be, where the emphasis should be. But the basic point I want to make is that measurement for quality improvement, most of which may never be public, is where we should be devoting our efforts. And we should try to restructure the health system so that organizations, or maybe down to the individual physician practice level, have incentives and requirements to engage in quality improvement activities and, in fact, develop measures that would work for that purpose, which is very different than the purpose of public reporting and pay for performance.
Can I just, it's not a rebuttal to Bob, but to round out the conversation there, I will just say we can have that conversation. I think it's important to have that conversation about the use of quality measurement, but we need to acknowledge the other set of stakeholders at the table for that, which are patients and purchasers who feel very strongly that there needs to be some kind of quality accountability. Until that cultural shift happens, I think we're going to, be living with the expectation that there is some accountability in terms of performance.
Government's responsibility anyway should try to protect beneficiaries, the consumers, from substandard care and not think it can distinguish between fair, good, and excellent care. And we should do a better job of protecting the public rather than trying to make those nuanced judgments. But that is a whole discussion that could take place.
Thanks, everyone. Rebecca Etz is up first, and then Chris Kohler after Rebecca.
So I had two questions. I really appreciate the presentations. Not surprisingly, I have a question about measures. I'm very interested in patient measures, patient-reported measures, and I'm very interested in quality measures. Thinking about accountability is a tough one for me. A lot of the accountability conversation so far, not in this group right now, but in general, has caused, it seems like a narrowing or reducing of responsibility among clinicians. They limit their panel and then they become accountable for what's going on with their patient panel, as opposed to being accountable for the health of the communities in which they're located. I'm curious about, for you, the kinds of measures that you feel would allow purchasers to get the information they need to understand how primary care is doing. So in addition to the patient measures, and maybe it's the same or maybe it's separate from clinical measures, but what would be the key things that purchasers would want to know to understand whether they're getting a good product, essentially? And just so we don't have to flip back to me after I've asked questions, for Bob, I want to make sure I heard you correctly, because it seemed as though you were saying primary care does not handle most needs for most people because, look, they're only paid 7% of the national health expenditure. And I wonder if some of the data you're using to describe what primary care does now is not a helpful direction. If we are underpaid and undermeasured, then looking at the end of payment doesn't necessarily say what we do, nor does it then suggest that specialists provide the majority of care simply because they spend the most money. So those are my questions.
Do you want me to go first, Bob? Or? Sure. So, let's set aside government purchasers for a second and talk about private purchasers. I have dreamt, salivated at the prospect of being able to give our clients metrics like days absent from work, amount of EAP resources used, metrics of distress, or even employees that leave their job because their clinical lives or their home lives are just so stressful that they're willing to incur that risk. I think about that for example, parents of autistic kids. So yes, I completely agree with you. I think as, perhaps I should just be more explicit. Implicit in my entire presentation, but I should make more explicit is these are all negotiations. They are multi-party, multi-directional negotiations between providers, patients, purchasers, and insurers. And I think where we trip up is that all those entities are hardly ever in the same room at the same time, at the right point in time in policymaking and execution. And that's the challenge. So when we talk about having the difficult conversations, it is, not everybody feels comfortable having patients in the room where you're discussing quality metrics. But I will tell you that at CMS, the original MSSP set of metrics was 64 measures long, largely because of advocacy from consumer groups. And today at Anthem, we're talking about a program where you pick 9 metrics from the menu, which I think is still too many, but at least they are outcome metrics. So there are all kinds of difficult negotiations that need to happen in a much more explicit, structured way.
And Chris, you're next.
So this is a question for both Mai and Bob. Thank you to all three of those, to all three of you. And maybe Carrie, you can jump in if you want. But I'd like to take Bob's observation that when he goes through the proposed primary care expectations, he posits that there's more coordination and complexity and less comprehensiveness. That strikes me as being pretty close actually to the vision that Christine Bechtel was pitching to us first, that primary care ought to be in the relationship business and focusing on the people who could most benefit from those relationships. So can you envision a future for primary care that is more focused on the needs of fewer people who could benefit from the coordination and complexity that Bob talked about, and that the other folk and people kind of self-select into that? And if a minute clinic or a telemedicine relationship works for them at a certain stage in their life, that's great. But as they approach these greater complexities, that's where they need the kind of stuff, that the expertise that primary care offered, the primary care expectations that Bob was talking about was offering. So I'm trying to connect the dots there. Thank you.
Yes, in fact, I think that many payers are starting to grapple with this now about how you tailor a primary care product, if you will, to different segments of patients and customers, acknowledging that there are different archetypes of patients with different needs at different life stages. Absolutely. I wanted to also underscore that I think there's a positive and an upside to Bob's interpretation of where we are. I think there is an opportunity for those primary care practices that want to practice more comprehensively to do so under the right payment and regulatory context. We're trying to offer that in Anthem through our Reimagined Primary Care Program, where we actually set out metrics of comprehensiveness of care, of scope of practice. The more you do of that scope, the less referring out for arrhythmia or dizziness, the more we'll pay you. So I think there are those opportunities there, and in the right communities, under the right settings, primary care can pursue that. But I do think this focus on relationships and really on the patients who need primary care most, it's not just the relationships. I want to underscore too that there's tremendous intellectual capital in the integrative problem solving, integrative diagnostic and problem solving that primary care does that is severely undervalued. It is not something that a digital tool or a machine learning tool can solve. You really can't solve for that with AI and a remote consult to a cardiologist, how to help someone who is having trouble because of cognitive decline and chronic illness and family concerns. Can't be done. There is no machine yet smart enough to do that. That actually requires an integrative brain at work. So I just wanted to underscore that too.
But to just respond to the last question where I didn't have a chance to respond is I do agree that we should be increasing the proportion of payment that goes to primary care, but mostly because their responsibilities based in their primary care practice have increased pretty dramatically, and we need to adequately support that. But I'm accepting the fact that other specialists will act as principal care physicians for many conditions, for many reasons, one of which is that the knowledge gap or the perceived knowledge gap is large and increasing as we get more nuanced in how to care for many conditions. And so the focus of primary care practices should be based about relationships. I agree completely with that. The term I used in my slide was the navigator of the healthcare system. That's the navigator to other physicians, to facilities, but it's also the navigator through insurance options to some extent, through certainly the social services once we figure out how to integrate social services and healthcare. I see the primary care physician or the primary care clinician better as the central focus of that. While I'm arguing we just de facto we're sort of losing clinical comprehensiveness, I would hate to give up the idea that primary care practices are the first contact. And so I think physicians have to primary care physicians and nurse practitioners need to play a much stronger role in knowing what's going on with their patients in the hospital. Maybe that can be one of the benefits of this new use of video conferencing, of Skype and all of that. I don't see any reason why primary care practitioners should have nothing to do with their patients in the hospital. They're responsible for getting them there, and they're responsible for picking them up when they come out. I think we can do a better job in that area. But what they have unique, what is unique is their relationship. Should a 23-year-old who has an occasional urinary tract infection go to a mini clinic? Fine. I have no problems with that. But for a large portion of the population, I think having a stable, long-term relationship with a primary care practice made up of a team, physicians, nurse clinicians, etc., is probably the way to go.
Tracy, who's next?
Actually, right now we don't have anyone queued up. I also see Kara Walker is back, so I don't know if anyone had specific questions for her.
Kara, I have a question. So I liked how you laid out needing a vision for primary care and to make sure that it became the focus as a foundation. I know in Delaware you laid out how you staged it so that the first requirement was to measure what was currently being paid to primary care, and the second was then to set the threshold. And I've heard you talk about some, but I wanted the committee to hear how were you able to convince your state to do that process? And I know you've advised other states on it. Chris was very successful in Rhode Island in getting there, but how can we help make that case as an option for other states? How can we help convince them that this is a not just viable but valuable option?
I think that the conversation has to start around total healthcare spend. I think without a conversation around that, it's very difficult to focus on costs in primary care and the concept of primary care, because physicians and others who are providing high quality primary care want to be part of that definition and part of the problem solving. But it was very clear that some of the question was very much fundamental around what do we mean by primary care? And we were a state that didn't engage in patient-centered medical home legislation or other fundamental pilot work that other states have done. And I think, again, that just showed that we had a lot more work to do to make sure we had an engaged and robust conversation around those who had felt maybe they were on the fringes. So having a place for independent, not necessarily mobilized and organized docs and nurse practitioners and physicians assistants to come together was critically important. Our state was, again, poised because we were talking about costs and what primary care meant because of our work around the benchmark and because of our work around defining these quality measures. You can't get to better health and lower rates of diabetes or obesity or high blood pressure control without an engaged primary care community. And so that allowed us to focus on how you get there. But these questions about what does the workforce of tomorrow look like? How do you train for it? How do you provide care for very complex older individuals who are growing in numbers in our state, I think was a very real concern that we tried to put into the conversation so that people could see there are trends, that we are aging, and that we really need to figure out how to invest in important areas. But the state was in a crisis, and I think it's unfortunate to be having these conversations, but you can't let a good crisis go to waste. COVID, we're in the middle of it. We are going to need to rebuild our healthcare system in many ways, and this is showing our weaknesses. I think this is, again, a way to just bring people together and make sure we're supporting a healthcare workforce that's robust and able to adapt, and one more reason for us to have these conversations. Thanks, Bob.
So as soon as I made that announcement, a bunch of hands went up. So I know we're running out of time. So I think we can get to one or two. So Hector and then Carrie Cola.
So I'm working on the integrated care chapter with my colleagues. And one of the things that's clear is that when we look at international comparisons, we have like the lowest duration of physician-patient relationships compared to other industrialized countries. And one of the things that struck me in all the presentations is the discussion of comprehensiveness, this tension that we have, that we can't really provide comprehensive care to everyone, and nor does everybody really want it. But part of Starfield's, I think, reason for comprehensiveness is that people are dynamic and they change over time in the course of their lives, and they will end up maybe not needing extensive coordinated care or comprehensive care in time one, but in time two they will. And so one thing we know is that our health system doesn't do care transitions very well at all, like changing people from pediatrics or adolescents to adults, or moving complex adults to geriatric care, and those sorts of things. So what I am concerned about is moving away from the Starfield conceptualization of comprehensiveness towards one that is like adapting to our maldistribution of primary care. And I do think there's risks in generating more transitions of responsibility across the life course. And so I do wonder the perspective of the panelists on this issue of we're creating more transitions if we allow, if we kind of open this idea that retail care could be okay at one point in your life and not at another. So it invokes this idea of more transitions and handoffs over the life course. And is that what we really intend? How do we do this without creating more problems, I guess?
So can I just say, I don't know that it's up to the clinicians to decide that. I'm seeing people vote with their feet when they go look for other modalities of care. It does not mean, for example, though, that a primary care group can't offer its own minute clinic and then have that as an inflow of new continuity patients. But the only other way to battle that trend, if the committee thinks that it's not healthy, is to offer a sticky experience and to present primary care as something other than a commodity. Right now, it has commodity status until you have chronic illness.
And I guess my point basically is it had to do with my own condition. I mean, I had chronic low back pain for decades. It then got severe, began to develop neurologic symptoms in my lower extremities, and my primary care physician, as you know, ordered. Finally, I passed my 6-week, actually passed the 50-year threshold for having low back pain before I got my MRI, and it showed that I had chronic spinal stenosis. It's a very common problem. He referred me to a physiatrist, and that physiatrist became my principal care physician for that condition. And one of his advantages over the primary care physician is that he gets to do injections. And he also knows the surgeons and who to go to and who not to go to on a much more practical, informed basis than my primary care physician does. And so, so I think we need to spend a lot of time figuring out better referrals, more informed referrals as to who to refer to. We need to be having not necessarily co-management of patients, but rather better communication and information flow between specialists and primary care. The primary care should be my home where this information is all maintained. And as I suggested earlier, for those patients who have 6 or 8 or 10 conditions and are on 12 or 14 medications, they may be the best place to sort out what's going on with a patient. But I just think what's happening just for various reasons is that it just in the system, well, to pick up my thing is I preferred to have my care managed with my physiatrist, not with my primary care physician, because he's a generalist. He is not a specialist on that condition. And so I think along with many patients, that's what they would opt for.
This is Kara. I think from the patient perspective, they want the right care wherever they can receive it. And certainly this is showing us that we can adapt in primary care to use telehealth and telemedicine, to use phone visits to more appropriately and safely manage people, and then to triage into those complex issues, that longer in-person visit. And so I think we're going to have to evolve where the Minute Clinic could be the right place and time, but it is for simpler issues that can be managed appropriately in a convenient way that patients feel like they're receiving high quality care. And there is some linkage back to that manager of the complexity so that if there are clues along the way of a higher level diagnosis, they aren't missed. But we don't necessarily have that continuum in place. And we certainly need to continue to think about how virtual medicine is keeping people at home longer, and we continue to leverage the home health space in a different way. And I'm certain that technology is going to continue to evolve to allow us to have accurate vital signs and other laboratory tests at our fingertips. But it certainly is changing rapidly.
I would encourage the committee to invite a firm like Heal Health to come and present about their model, where you can see in action a disruptor, one who is trying to present primary care in a way that begins as a commodity in the beginning of a relationship, but that rapidly builds into something much deeper, more meaningful at the point of care, which is in the patient's home. Just as one alternative vision.
Tracy, we have time for one more quick question.
Actually, I think we're out of time, and I've been in touch with the people in the queue, and so we're going to follow up with the speakers separately if they have follow-up questions.
Thank you. We're going to take a break until 1 o'clock, but please come back before 1 o'clock and get back on. And again, for the public, we'll be holding your questions till 2:30 after we finish all of the panels. But you have that opportunity in the box of the webinar to send us questions in the meantime. Hi, this is Bob Phillips. I'm welcome back to the National Academies Ad Hoc Committee on Implementing High Quality Primary Care. We're going into our second panel of the afternoon, and who I'll be introducing in just a moment. For folks who may be joining us new, if you're a public participant, know that we will be having questions from the public at 2:30, and you have an option to put questions into the webinar directly for us to receive. It's my pleasure to open our next panel on delivery system innovation, challenges, realities, and opportunities. And our three speakers this afternoon are Dr. Toyin Ajayi, who is the Chief Health Officer of City Block Health, which is a New York-based health and social services company focused on enabling a path to healthier communities. It focuses on how to bring together and integrate the medical, behavioral health, and social service delivery models for low-income Medicaid populations with complex needs. And prior to going to City Block Health, Dr. Ajayi was Chief Medical Officer of Commonwealth Care Alliance, which was a nationally renowned integrated health plan and care delivery system for individuals who are duly eligible for Medicare and Medicaid. She's a board-certified family physician who continues to practice primary care and hospital medicine. Our second speaker is Dr. Kelly Kelleher. Dr. Kelleher is a pediatrician with research interests focused on accessibility, effectiveness, and quality of healthcare services for children and their families, especially those affected by mental disorders, substance abuse, or violence. Dr. Kelleher currently holds the Schlapity ADS Endowed Chair for Innovation in Pediatric Practice and is a professor in the Department of Pediatrics at the Ohio State University. And our third speaker is Dr. Doug Eby, who is Vice President of Medical Services at South Central Foundation in Anchorage, Alaska, where he's served on the leadership teams for both SCF and for the Alaska Native Medical Center since 1995. He has played a key role in the development of South Central Foundation's innovative primary care system and speaks nationally and internationally on healthcare system design and quality improvement. So thank you to all three of our speakers. They'll be going in that order. So Dr. Ajayi, I open the floor to you.
Thank you so much. It's a real pleasure to be here with you all. Can you hear me okay? Great. It's a pleasure to be here with you all virtually. First, just some disclosures. My apologies. I don't have fancy slides or a lovely deck for you all. As for most of us, we've been pretty consumed with responding to the unprecedented coronavirus outbreak, particularly in our communities here in New York, where I'm based and where I practice. But actually, I think in some ways, this frame of where we are right now helps to provide a really interesting lens through which to talk about the role of primary care. And perhaps to illustrate a little bit of how we think that the foundations of some of the more novel primary care models, of which we are one, actually have relevance for this moment in time in particular and beyond. So I'll start by telling you a little bit about myself, very briefly, a little bit about our organization, City Block Health, and then focus in on four key components of sort of primary care of the future, the way that we've seen it, and talk in some detail about both how in the pre-coronavirus world this was playing out, but how in particular this I think will have real implications for the future. And then I'll wrap and join you a little bit later for the open discussion. So I'm a family doc. I trained in Boston at Boston Medical Center. I have long been deeply passionate about care for underserved communities, in particular for populations with physical, behavioral health, and social needs. I'm sure that as context for a lot of the work that you all are doing, you've spent time thinking about and just reflecting on the multitude of graphs and charts that illustrate the disparities in health outcomes across our country, all of which cleave along lines of income, disability status, race, ethnicity, geography, rural versus urban, and all of which are getting worse as we continue to see particularly income disparities cleave similarly along those lines and impact access to care and services. That passion for me has led to building and trying to scale models for effective community-oriented care for these subpopulations. It's no surprise that because of my background and I think because of some of the values that we all share as a group, I really believe that primary care is a core tenet and a core part of the toolkit that we have to improve outcomes for populations across the board, but particularly for people with complex needs, and have spent my career focusing in on how to deliver effective, high quality, high value, person-centered primary care to the most vulnerable populations. I am the co-founder and the chief health officer of City Block Health. We're a New York-based company with operations in New York, in Massachusetts, Connecticut, and North Carolina that specifically serves underserved communities by contracting with health plans to take total cost of care financial risk and attribution for high-risk populations. We provide primary care, behavioral health, and social care, and I'll talk a little bit more about what that means, in a fully integrated model, with our three core goals being to improve patient satisfaction and engagement, to improve quality outcomes and reduce disparities, and to decrease the cost of care for these populations, really aligning around the triple aim. And I'll talk with you about what the levers are that we think are important, including the use of technology to drive those changes. So I think the 4 key tenets that have emerged through our organization and others that have really been starting to push into this space is a desire to radically transform what we think of as primary care and the way that we deliver it to communities. So we'll start with physical location. And in no moment, at this moment in particular, is just such a stark reflection for us about how much of a fallacy are anchoring on physical space, clinics in particular, as the locus of care has been. Traditionally, primary care has required people to come to a clinic to do the traditional things, wait for the doctor or the advanced practice clinician, get their however many minutes of care that they receive, and go home to carry out the instructions that have been given to them or not. And we recognize that many patients have tons of barriers to medication adherence, to behavior change that are not visible to the clinician in the office environment. And they have many barriers to getting into the front door in the first place. We understood that and have really been focusing on meeting people where they are. And what that means is providing significant services in the home, either physically through our care teams that deploy into the home to go see people, provide clinical visits in the home, social visits in the home, behavioral health visits in the home, as well as virtually, and recognizing the ability to engage with people asynchronously and synchronously through technology. So SMS is a really powerful modality. We find that about a quarter of our patients on Medicaid in particular, prefer to text as their primary mode of communication, even with healthcare. And using readily available tools for SMS has meaningfully improved our ability to engage with people, to follow up with them, to actually do triage and do chronic disease management. We find that telehealth, so video visiting, before coronavirus was really tricky. It's hard to get people to adopt. But as soon as we have an impetus to ask ourselves, what can we do with technology that doesn't require people to come to us, we discover actually that there's a tremendous amount we can do. The tools are there. Patients are excited and amenable to engaging in them. And again, it allows us to show up where people are, which is at this moment in their homes, and still continue to provide the level of care and engagement that they need. And then, all things being equal, I'm recognizing that there is no substitute truly for real face-to-face human contact, and then that contact has to be mitigated and brokered by people who are familiar, culturally competent, culturally synchronous with the community that we're serving. We hire a large workforce of people who are from the communities we serve. We train them and equip them to meet members in their homes and community centers and Dunkin' Donuts, to accompany them to visits, to simply be where they are and help to eliminate barriers to access to care wherever they may be. So that's tenet number 1 that I think particularly right now, I think is so critical. We've got to meet people where they are, and primary care has to think about itself as spanning far beyond the 4 walls of a clinic, and of its reach is spanning far beyond the 10 minutes of a provider visit that it is typically encompassed. The second core tenet is around the integration of physical health, behavioral health, and social care. This is the notion that our members, our community members, our patients deserve no wrong door to accessing care. And when you look at populations who particularly have significant risk for high acute utilization, for high costs of care, for poor outcomes, for morbidity and excess mortality, these are folks for whom the traumas of being poor, of being underserved, of being marginalized show up in their lives in so many ways. And behavioral health is a mainstay, primary behavioral health is a mainstay of primary care, is just a fundamental concept we have to embrace. It is not possible to help somebody who is struggling with depression or anxiety or post-traumatic stress disorder to manage their insulin and manage their hemoglobin A1C unless you address the underlying behavioral health needs. And the typical model of handing someone a referral to a social worker whose office is often the most crowded and, the windowless closet in the clinic somewhere is not going to suffice. We've got to be able to deliver those services to people when they need it, with a team that is equipped to address and to respectfully manage those needs. And co-location is not the same as integration. So we did the experiments early of having a psychiatrist on site in the clinic, in our FQHCs a decade ago. That's not the same. It's got to be cross-pollinated throughout, which means that our behavioral health teams have to understand physical health, and our physical health teams have to understand behavioral health. And all of us have to think of ourselves as behavioral health providers as much as we are primary care providers. And then social care, recognizing, we've used all sorts of terms of late, social determinants, care management, care coordination, all of that. What we're saying effectively is that who the human is, where they live, where they sleep, what they have to eat, who they talk with, how they live their daily lives matter to their health. We know that. We also know that we have to understand and address barriers for folks in order to help them achieve their best outcomes. And that, again, passing that off to a social service organization, in the form of a piece of paper with a set of phone numbers that we give a patient a call is not sufficient. That's not service delivery. So asking primary care in this new world, and particularly in the era of coronavirus and beyond, to understand what the social needs are is critical for our population. We, over the last couple of weeks, have built out specific risk screening tools for folks who are at highest risk for social never events, I would call them. In the context of coronavirus, we identified hundreds of people who have not enough food to last them through the week. We identified people who don't know where they're going to sleep. And in a time when being able to just nourish yourself and sleep in a safe, warm place is equally important to your health and well-being, if not more than anything else we can be doing from a healthcare perspective, we've got to solve those, and primary care needs to own accountability for those as well. The third core tenet is value, is moving to value. And we've seen, tremendous tailwinds over the last several years, pushing providers to value-based care. The notion here is that we have to figure out a way to align incentives from care delivery all the way through to outcomes, such that people are incentivized and compensated to deliver better outcomes for our members, as opposed to doing more and frequency of visits. We've got to be tied to value and to outcomes. And so the type of relationships that we build with payer partners, where we are at financial risk, tied to quality as well as tied to clinical outcomes, is the wave of the future. And I think will enable primary care in the future to make the types of investments in behavioral health and social care that they need in order to help their populations get better. And then the final piece is around building trustworthy systems. And this, I think, is so critical. If we're asking our primary care providers and our primary care delivery organizations to truly be accountable for a multitude of needs beyond diagnosis and management of physical health conditions, which is typically what is our purview, but to drive outcomes for the populations that we serve, many of those individuals touch multiple different parts of our system all the time. They're touching food banks and shelters, and they are working on housing, and they are going to the hospital occasionally, and they're coming to primary care, and they're seeing the behavioral health provider. We've got to figure out systems that allow us to know what's happening to people and with people and for people, to have a really clear source of truth about what their meds are, what their needs are, to be fully accountable to being accessible to our members. If we say to our patients and our community members, call me anytime because I want to get you out of the hospital, I want to make sure that I'm there for you, that system has to be trustworthy. And I think that we've built in healthcare technology tools that are not actually geared towards fidelity of service, to making sure that if we make a referral, that referral gets carried out, to making sure that if we give someone a phone number to call, someone answers it every single time, to making sure that when we say we're going to follow up on something, we actually do. When we make a connection for a patient, when we change a medication, that actually flows through to every resource beyond that. And so building trustworthy systems from a technical and an operational perspective to underwrite and support the infrastructure that we're hoping to deliver, I think is the fourth and really critical hallmark of the primary care delivery system of the future. And in this moment of time when we are under unprecedented stress, I will tell you that we're pulling on all of those levers as much as we possibly can. We're seeing our members in their homes. We're reaching out to them via every modality we possibly can to identify folks who are at risk and make sure that we're meeting their needs. We're providing a tremendous amount of behavioral health and social care services right now. We're focusing on keeping folks safe at home and out of the hospital to the extent that we possibly can. And we are building and reinforcing technical tools to make sure that we can do this with fidelity every single time. So I hope that was helpful, and I look forward to talking a little bit more later.
Toyin, thank you so much. Perfect timing. Dr. Kelleher, are you prepared?
Pop up the screen. I hope you can see in a minute. Yes, hi, this is Kelly Kelleher, and thank you for the opportunity to speak today. I appreciate the work that you're doing and the important work you're doing. But I like Toyin, my slides aren't as pretty as they would be if my staff were here to help. And not only that, I think the work that we're doing right now with COVID is emphasized how radical we need to be in thinking about primary care. So I want to run through these early slides and really spend time at the end on things we normally don't talk about in primary care. My goals today are to talk about the who, child primary care and accountable care organization run by providers, what, the trends that we're seeing in primary care, why we focus on children specifically, and how, the things we don't talk about. So who, I want to talk about particular Partners for Kids, which is our ACO for Medicaid enrolled youth. Partners for Kids is 1,900 providers, about 1,500 of whom are primary care physicians in central and southeastern Ohio with Nationwide Children's Hospital. We have about 325,000 children, and it's a 501c3 charitable organization. It will be expanding next year to fully half the children in the state of Ohio, 500,000 children. And for pediatrics, that's a large number. There's nothing like that out there. All Medicaid youth. The funds flow is complicated. Ohio Department of Medicaid contracts with managed care plans to contract with Partners for Kids, and then Partners for Kids pays the medical care providers, and surplus is reinvested into child health programs, and specifically into our housing programs, our employment programs, and our education programs for children, because without these things, our areas of concentrated disadvantage, which are really high-cost Medicaid areas for Partners for Kids, would continue to cost us more in the long run. And I hope we get a chance to talk about that. But the primary care features and the aspects of our network, which is about 1,500 practices, really fall into two groups. Those that are contracted with us as core network and those that are non-contracted. And the core group, even within that, comes to us as practices. And I think this is the fundamental challenge in primary care consideration. I've heard it this morning already, the conflicting discussion about whether we're referring to practices or a service. And when we refer to practices and clinicians, we're being clinician-centric or site-specific. And when we're referring to care, we're referring to patient-specific and less site-specific. And that's what we're able to do with our contracted practices as a network, to be a really integrated medical neighborhood such that our children's hospital employed practices, our private pediatric practices, and COPC, a large private group that engages with us, can take advantage of our entire range of services and support so that they can be comprehensive and higher quality. The FQHCs, county health centers, private offices, retailers, and online are all growing rapidly in our area, but they are not currently integrated yet, and it's one of the challenges of network-based practice. But what does happen is quality distinguishes itself, and so what we see, and I'm going to fly through these, they'll be submitted, and they're in the with the committee so they can look at these, but HEDIS measurements, ADHD quality prescribing, utilization of preventive services versus ED and inpatient, they're all better with our contracted practices and improving over time compared to the non-contracted practices, which are actually declining over time. So we see that with our asthma as well. And I'm going to leave you these slides and not spend time on them because we could go over each one in some detail. But our efforts really show that our primary care contracts allow us to act as support services for the practices, because practices, we've done several studies funded by NIH with ADHD, several on depression, and a couple others on asthma, and none of them show primary care practices individually being able to manage longitudinal responsibilities in complex organizations over time. And even the best practices struggle with registry maintenance in multiple different conditions. So I'm trying to be contentious and hope you'll argue with me a little bit on that. But I think really network-based primary care is really the only way that pediatrics will survive in primary care in the future. So what trends are we seeing? Well, our trends are much like you're talking about already this morning. We do have increased nurse practitioners and PAs, and in fact, we are assisting private practices in outlying areas to recruit those people to their practice instead of seeking MDs or DOs all the time. We are exploring pilot peer-based and parent-peer models to support practices and provide support for those families in practices. We're also doing primary care enhancement with specialists using Project ECHO on a growing basis, a very high demand, and quality improvement coaches from the network. So expansion in the number of services that we can offer to the primary care practices as a network. And the location is, of course, expanding as well. The number of school clinics we are conducting for the state of Ohio, school-based clinic development for FQHCs around Southeast Ohio, and doing consultations and setup seminars. We're also offering assistance to retail pharmacies and retail services that want to align with us and integrate medical records, and providing more and more text messaging for certain, especially in our Medicaid population. And then, of course, consolidation and corporatization. And consolidation is very hard in pediatrics because large organizations, the very largest hospitals you can name in the state of Ohio and Pennsylvania and Minnesota are buying practices and asking them not to accept Medicaid children because it's not good for the bottom line. So as pediatricians, we're losing our best practices to large consolidation, even though we have an extensive network that covers most of the central and southeast parts of the state. Our practices are being picked off one by one and being told, don't take Medicaid children. So this is, pediatrics, and not just pediatrics, but child health is being subjected to the Medicare advanced funding streams, while Medicaid is being left behind again. Digitalization is happening in self and group care. We could talk about that. We have a number of research projects in that area, but it would take a lot of time to go through those. These are just the trends in the annual change in office visit, with increases for NPs and PAs and decreases for our pediatricians. We're seeing this locally. And I wanted to talk about why a special focus on children, so I can really get to the contentious stuff. So children have a different range of visits coming in. The components of preventive care and acute visits are much, much higher. So when we distinguish between pediatric visits and we look at the number of visits that are chronic complex care, chronic conditions, that's much fewer in a pediatric setting. So when the state does CPC Plus or another such kind of funding tool, pediatricians and family practices that see a lot of children get a lot fewer dollars for coordination of care. And that coordination isn't sufficient to hire new staff. So we don't have diabetes coordinators or congestive heart failure coordinators or patient educators that can serve in one single practice. They actually have to be networked. So for example, our suicide prevention coordinator and behavioral health screening coordinator covers 10 practices at a time. And so the idea of providing everything within a medical home versus a medical neighborhood is quite different. Plus, this model, this is a slide from American Community Survey and Child Trends, and just shows that nearly half of children rely on government-sponsored health insurance. And after COVID, I expect this to increase by 10% across the country as we see, a 20 to 30% employment rate that was talked about in the Wall Street Journal yesterday. We're going to see a rapid rise in Medicaid rates. And with so many physicians around the country refusing to accept Medicaid, children will not have access. This is the number of primary care physicians that accept Medicare versus Medicaid. And just the top two slides are Medicare, or top two bars are Medicare and private insurance, and the bottom bar is Medicaid, and this is where our kids come in. And you can see that most non-pediatric physicians don't accept nearly as many Medicaid patients as they do Medicare and or private insurance. And of course, when they do, they cap them. Pediatricians are not much better. And it's not great, but I'll leave these slides. The bottom line here is Medicaid is increasingly less and less accepted by pediatricians, and they have caps on it. So for our network, what we have to do is actually pay extra bonuses for practices to open up their practice to all Medicaid patients. So we actually pay a multiplier when practices join our network to get them to open up their practice. And then we gradually transition that access bonus into a quality bonus over time. So this is what I really wanted to talk about, things that we prefer not to talk about in pediatrics and in primary care in general, and just spend a couple minutes. I don't want to go through individual slides because I don't think they're helpful, but first of all, we ignore in accountable care organizations and in our networks and basically in pediatrics, rural children and access. And we have increasing evidence that children in rural areas have greater rates of developmental disabilities, mental disorders, suicide, a growing rate of problems with a declining tax base and diminishing services. And yet we have not addressed that in primary care and in pediatrics in particular. And I think we have to do that. Poor children in this country, we're not only not taking Medicaid patients, but in other areas, law, in education, in transportation, in retail, we have said separate is not equal. But for poor children, we are saying it's okay if poor children have a separate system called FQHCs and community health centers, and pediatricians and other private primary care docs don't have to take care of them. Now, it may be in some places that's a great solution, and I know the FQHCs I know with are working really hard, but they're working with poor resources and lots of turnover and not really the care they need, and certainly not the support from the academic centers. So separate does not mean equal, in my opinion. And if we don't address separate and unequal, then we have a problem. Babies and mothers. Primary care has not been involved as extensively. We've handed off the care of maternity care in many ways. And as a result, babies and mothers are getting ignored so that maternal mortality is on the rise. And there are many other reasons for that. But I think that we have ignored the linkage between infant care, maternity care, and what needs to happen there and the communication of data. Managed care companies have maternity data. A network like ours has pediatric data. They're not connected and not shared. That's consistent in many states. I put pediatrics here. I already mentioned the one case where large networks are coming in saying, focus on the Medicare patients, no new Medicaid kids. And we're seeing that also when we try to do care coordination within practices and place our care coordinators with practices. Yes, children do not pay as well. And we are going to have many, many more poor children. And in my mind, this is the great travesty because we know now that the vast majority of adult, early identifiable chronic disease starts in childhood and adolescence. And so if we really want to bend the cost curve, we're going to start to focus on healthier children, but we're missing that point. We already heard people talk about mental disorders, and I put primary care here as things we don't talk about, things that don't matter, because the bottom line is when I talk about this to other institutions and talk about ACOs, all of the major cost savings out of ACOs have so far come out of specialty hospitalization and regionalization. They have not come out of primary care. But primary care access for the most vulnerable matters a lot because that's the main connection to social services in communities. So if we don't set up the social service connection that we just heard about, if we don't have the integration of not practices, but primary care with social services, I believe we're going to miss the boat on this. So what are the challenges? I think we have a failure of a practice model. We've confused practice with primary care rather than a care model, a network, a neighborhood. I think consolidation and contracting are radically altering the focus on high-pay patients rather than and marginalizing children, poor, rural, and minority. And our opportunities are really to have population health goals. So this year, Nationwide Children's Hospitals and Partners for Kids worked with the county and city to set 10-year goals for population health for all the children in the county, independent of whether there are patients or not. Our primary care practices make up 25% of all those patients, but we're going to be working on all 100% of the kids over the next 10 years. And I think until primary care commits to population health, which is what it's really designed to do, we won't get there. Barbara Starfield was my mentor at Hopkins, and she preached community and care. She didn't preach anything about practice. Improving personalized care for panels, I think we really can personalize this with texting, outreach, and this COVID requirement. We're going to have a major depression with radical increase in the number of Medicaid poor, much lower state and Medicaid dollars in the future per membership, per person, and we have to figure out a way to address that. Thank you.
Kelly, thanks so much. We really appreciate it. And we'll come back for questions after Dr. Eby's presentation.
That's as soon as I can stop sharing for you.
Hi, this is Doug Eby. Can you hear me?
You sure can, Dr. Eby.
Okay, slides up. So our story is taking a whole medical system, again, a mixed payer environment, which I'll try to get to and explain, and then taking the entire system and redesigning it from stem to stern and running a very primary care-centric thing, which is why the title is Massively Powerful Primary Care. And one of the great things I believe very strongly is that primary care has largely abdicated its role in this country and actually literally all around the world, and that's extremely unfortunate and not something that has to be. Our company it's a private company, locally owned, consumer-owned, and consumer-driven. We employ about 2,500 people. Our sister corporation, the Alaska Native Tribal Health Consortium, employs about 3,500 people. So thousands of people supporting hundreds of thousands of people in a whole system approach. The way to get to primary care that actually works, though, is to rethink everything about primary care and to base it on a very different paradigm, and then to pull in all other services. This business of over-specialization and specialists and so forth, we'll get to that in a little bit, but it's a huge part of the problem. And if Bob Berenson is still on the line, even your issue with the physiatrist and the role of the physiatrist, we have an answer to within our system. So the reason a lot of people listen to us is because we have actually produced, sustained over decades, the triple aim. So we've dropped dramatically use of specialists, ER, and hospital stays and emergency room visits while improving financial performance, dramatically dropping cost, very high satisfaction by people working for us and people getting services from us. And our population is a high-risk, challenging population, and we've moved from the bottom 5th percentile to the top 25th percentile, so at the 75th all the way up to the 99th percentile, pretty much every single clinical outcome that you can measure. And just to say something about measurement, the classic medical outcomes we're happy to be accountable for. We want to produce other things, and too many people talk about primary care as if its main purpose is screening and prevention and health, which we certainly believe in, and those are priorities for us. But the big return on investment in primary care is in health, well-being, and chronic conditions, and dramatically decreasing the use of expensive things. So you can get a 6-month return on investment by massively increasing your investment in primary care, while also getting decades of improvement in other things. It's the whole package. So here's the other set of measures we think are extremely important. In fact, these are more valuable to me than the health outcomes to some degree. That availability is extremely high. Cultures and traditions respected, 97%. Trust, 99%. Provider listen carefully, 98%. I got the right amount of attention, 97%. I was given enough information to make my own decisions at 98%. That's just remarkable. We also are the only healthcare organization in the entire United States to have won the presidential national Malcolm Baldrige National Quality Award. This is one of the most difficult things to get. Still the only healthcare organization in the country to actually win it twice. And so we didn't get this by being the cute little native place in Alaska, but by actually doing transformative work sustained over decades across thousands of staff and tens of thousands of people using the system. The financial environment, just so people don't write us off as something unique and weird, over half of our money comes from visit-based volume, fee-for-service, terrible way of getting paid. We get a block grant from the Indian Health Service for the tribal part of what we do. We also get money. We run 14 FQHC community health centers. We provide thousands of veterans, native and non-native services. We are big players in behavioral health and addictions. We also do lots of research, and of course, we pursue grants and philanthropy and all of that kind of stuff. In terms of costs, we cover all costs. So everything from medical visits to pharmaceuticals, expensive residential treatment programs, addictions, optometry, dental, the whole 9 yards. And if you look at our per capita spend, despite being the most expensive state in the U.S. in terms of per capita spend on average, we are at 2/3 the average for the entire U.S. So remarkably better outcomes in a dramatically challenging physical and social complexity environment for less cost with top-of-the-line clinical outcomes and satisfaction. We do it through a transformation of an entire system. This is just a picture to let you know we are a big system. We and our partners run a big tertiary medical hub, support lots of satellite hospitals in addition to clinics, and then tons and tons of community-based people, expert patients, and lots of team-based approaches. Of course, in Alaska, it is always beautiful and the mountains are always fantastic. The core problem across the entire world, and because we've become a little bit famous, we do consulting and advising literally all around the world. And so we have interacted with health systems all over Europe and Southeast Asia and also, South America, all kinds of different places. And there are two big problems. One is how money is used and distributed. And by the way, I agree with Bob and others that individual pay for performance is corrupting, awful, evil, ought to be burned and torched and dismissed from humanity. But there are lots of things about how money is messed up in lots of other ways, which is a whole conversation in and of itself. But the part that's often missed is this other part, which is the over-reliance and consuming belief in the medical model. So even when we work with single-payer systems in Europe and Australia and New Zealand, they are actually the most interested in us and what we've done because they have not messed up the money side as badly, but they're still thoroughly messed up in this over-reliance on the medical model, the idea that the body's made up of parts and centers of excellence and specialists somehow are the answer, and that you must come to our physical temples and follow our rules and get naked and do all kinds of things in order for us to do anything worthwhile. All of that's just complete crap. And the idea that then we judge people, so we are the all-knowing people who give you a diagnosis and a treatment plan, and then when you don't perfectly do what we tell you to do, we call you non-compliant in our authoritarian, arrogant, narcissistic, and completely offensive way. So let's talk about what we do instead. So I agree very strongly with our first speaker, Christine, this morning, who was talking about relationship and connectivity and so forth. We believe that that is the fundamental core of the business that we're in. Relationship, shared responsibility, the idea of customer ownership, connecting through story, and deeply understanding what complex adaptive system theory has to tell us and so forth. So let's explore this a little more. This is always my favorite slide. On the right hand is high acuity environments within which using Six Sigma manufacturing processes and so forth makes sense because the patient, or what we call the customer owner, has little to say and we're doing things to them. But in most of healthcare, it's the other end. It's the lower acuity, people living with chronic conditions and challenges, either from simple to complex. And in that reality, the people in charge are the patient or the customer owner or the individual and the family, influenced by their environment, but they're making all the important decisions. Do they pick up their meds? Do they actually take them as prescribed? If they get, 20 different medications from 7 different specialty protocols that they go see, because of course we have to fragment them in modern medicine. The people who decide what they actually take and don't take is them, influenced by the people around them. They decide what they eat. They decide about drugs and tobacco and sleep patterns and exercise and how they handle frustrations and anxiety and tension in their lives. Those things are under their control. The only question is, how are we going to respond to the fact that they are in control? So what happens then is understanding that just medical people doing whatever they want, that's chaos in the top right-hand side of this Stacy diagram. And modern medicine's answer has been to try to protocolize and standardize everything, which is on the bottom left, and all of a sudden manufacturing and Six Sigma and Lean have become the answer to everything. Well, that's also crap, because that works for 1/3 of what we do in healthcare, which is in high acuity environments where the patient or the customer owner is passive. It does not work for 2/3 of the cost and 3/4 of the people involved in healthcare. You need to be in the middle. And this middle area is called complex adaptive system theory. I'd love to spend a half an hour on it, but I get very few minutes here, so I'm going to move along. But basically, everything about how you get excellence in relationship-based primary care is almost the opposite of what modern medicine is preaching these days with the Six Sigma Lean and all that obsession. We're big believers in that, but only for 1/3 of what we do. For 2/3 of what we do, it's almost exactly the opposite. Which leads me to this slide, which is healthcare is about 1/3 manufacturing and ought to use manufacturing excellence models for what they do. But that is not where primary care lives. Primary care lives in the part where we walk with people over time with their challenges. And that is a service industry platform, which means complex adaptive system theory, a whole different understanding of the business we're in and what excellence looks like and what methodologies and tools are actually going to stand us in good stead. Again, a whole presentation to be done there, but moving along. This is what we've actually done in primary care in terms of structure. We have said our job is to be your lifelong companion, partner, advisor across all service categories and locations, never leaving your side no matter where you are in the system, and providing that advice, coaching, support, and cheerleading, and then drawing services to you and us in that partnership, which means a complete reconfiguring of the entire medical system. So let's build this from the core up. So you have the customer owner and their family in partnership with the primary care team, which to us means a primary care provider, a case manager, supported by CMAs and what we call case management support, sort of our own little local invention. And then each of them have about, we're down to just around 1,000 now, so this slide's a little bit old. We keep shrinking the panel size because to do outstanding work, you have to have the availability and time and energy, so you need really small panels. So we're at about 1,000. And so for every 5 or 6 then of these teams, there are 2 behaviorists, a pharmacist, a dietitian, a couple midwives, and actually now a social worker. And I'll get to lots of other integrated co-located specialists as well. And then there are coverage people and so forth to help them do their work. All these people exist only to interact with the people that are connected to them. They have these other people do not have separate rooms. They do not have separate schedules. They're in the same physical environment, 2, 3, 4 feet away from each other. So very congested COVID sharing environment. Haha, that's a joke. So this is then sort of the diagram of the whole system. So customer owner family in the middle with their never leaving their side, always present primary care capable team that they know on a first name basis and know them on a first name basis. All barriers to access removed. For over 20 years now, we've guaranteed same day access 5 days a week, all day, every day to these people who know you by any modality you want. Phone, text, email, in person. It's up to the people to decide how they want to interact. For 20 years, unfettered, unblocked access to people who know them. And then co-located are a whole bunch of people, which I'll get to in a minute, and then reconfiguring even the specialists who are not co-located, which I'll get to again in a minute. So what we've done, made fully accessible, relationship-based, completely connected, first name basis, available to you however you want to be connected to, all day long, every day guaranteed for over 20 years. And then we've layered in expertise. So rather than sending you to experts and centers of excellence, by the way, the whole idea of centers of excellence and specialist-centric thinking and structure is just offensive. It's just terrible. It's inefficient. It's dangerous. It's ineffective. It's fragmented. It just makes no sense at all from a human design perspective. So we've pulled specialists into our physical space and integrated them. So we have HIV specialists, diabetes, obesity, chronic pain physician, chronic pain psychologist, physical therapist. We have complexity expert, adult experts, pediatric expert specialists. We have aging and well expert, palliative care, psychiatrists, addiction specialists. We have all these people, lactation specialists, midwives. They're all physically in primary care, and their entire purpose in life is to help the generalist platform do outstanding excellence for everyone, no matter what their complexity and what their diagnosis. So there is another layer of other specialists, right? The cardiologists, the neurologists, the pulmonologists, the ENTs, the orthopedic surgeons, and they are not physically in primary care, but all these people are physically in primary care. So those other specialists, we've just had to retrain them to quit being center of excellence destination people, to instead be facilitating, coordinating, supporting, teaching, consulting supporters. And we've done very well at that. I'd say 90% of our specialists understand that their job is to be immediately available to this generalist platform whenever they need them. So like our cardiologists understand that if they can connect by phone or video to a real conversation in real time that's happening between the primary care people and the customer owner, if they join in real time within 5 minutes, they can avoid 80% of the visits to their office, leaving time then to do the stuff that they have to do in their office. And since everyone in our entire system works on salaries and there is no perverse pay-for-provider crazy crap distracting them from what they ought to do, they all do the right thing. We run the system with global budgeting and global planning and global thinking so that there are no perverse incentives built into the system at any level. But again, remember, we are mostly still in a fee-for-service environment and so forth. There really isn't much managed care in Alaska. We do get some block grants from other people, but it's still mostly fee-for-service. But we think and act as an entire system. We budget as an entire system. Revenues are shared across the entire system. So we do the right thing and then figure out the money. The reality is we lose tens and tens of millions of dollars in revenue that we would be making if we ran in the usual way. But we've also dramatically reduced costs, somewhere to 34 to 40% reduction in per person cost because of how we think and act. And this is a simple financial math that modern medicine does not seem to understand, which is if you drop costs faster than you give up revenue, your margin still improves. So we can come back to the money side if you want, but even in our crazy financial environment, we've made this work very well financially. So then in addition, we have home visiting people in all sorts of different categories. We have social workers, community resource workers. We have learning circles. We have tons of lay experts, expert patients. We have over 75 different types of learning circles run, all different locations, all different times during the day that are run by, quote, expert patients or community members supported by our staff in a very sophisticated way, which I don't have time to expand longer. So the principle here is the people are living their lives, and it's our job to weave our services and expertise into their lives at their convenience with people they know and trust on a first-name basis, who then pull all other expertise and resources into that relationship. So we've eliminated disease-specific approaches and only do whole-person work. So we pull specialty stuff in, and then we have this massively capable primary care. It turns out if you don't artificially constrain the system, yes? I'm down to my last 5 minutes. I'll finish.
We've got about 3 minutes left, if that's okay.
Yep, nope, and down the home stretch.
Thank you, sir.
So if you don't mess with people, it turns out that if you let the system be consumer-driven, you get about 50% asynchronous and virtual, text and email, 30% synchronous virtual phone, video, 20% visits. This is not created by us. This is in response to how people want to interact with us once they have long-term trusting relationship. Completely consumer-driven system. This is the physical environment within which people sit as teams. We have to then retrain all of our staff in the ability to give and receive story, deeply understand who they are, constructive conversations, coaching, advising, mentoring, and so forth. We have a massive workforce investment, an entire building based on nothing but changing the habits and knowledge and skills of our staff, deeply embedded in this idea of customer ownership. We teach them a lot of self-awareness and self-knowledge, but also how to connect and so forth. One specialty story, just to give you some data. So HIV, we don't get to fire anybody. This is all comers in our population who are HIV positive. We have one specialist who helps our generalists do perfect HIV care. 99% of our HIV positive people are in relationships, 98% getting perfect services, and 87% with undetectable levels of virus. There is no HIV clinic, no HIV specialist you go see. It's all done by generalists supported by a specialist. Just one example of repeat over and over. And then since we don't have time to get into our villages, we support tens of thousands of people in very remote locations with completely different alternate workforces. We have community health aides, which are many medical people, behavioral health aides, many behavioral health people, community health reps, many social workers, dental health aides who do drill and fill, and lots of oral health. And then we support this all through a very sophisticated telemedicine support process. We even have very standardized technology in every single village in Alaska, supported by pharmacist-managed dispensing of pharmaceuticals. And then this is all supported by an incredibly sophisticated infrastructure with a massively capable data mall, huge development center, workforce development investment, but it's all based on what the consumers and the people and our customer-owned and customer-driven people say they want and need. All of us in senior leadership together spend about 40% of our time deeply embedded into communities and voice of people and so forth. We don't just have customer voice occasionally on the side. As Christine said this morning, Christine Bechtel, this thing ought to be driven, owned, managed, and driven and designed by the people who use the system, and your committee ought to have at least 50% of its membership be patient reps and customer owner voice. And with that, I will stop for now, but we've spent 25 years redesigning this entire thing stem to stern, and we've answered every single question from measurement to staffing to system flow to design to how you bring specialists to how you handle transfers, even in inpatient. We believe in pull discharges from hospitals, not push discharges. So it's all been completely worked out here over the course of 25 years. I'd love to share way more in person, and I'd challenge your committee to come and get to know us more deeply. Thank you.
Dr. Eby, thank you so much. And again, I am not pulling prerogative. I think my hand was the first one up. That's a challenge for the rest of you. Dr. Eby, I'm going to start with you. Just a very quick summary of what I heard to lead to my question. I've only seen a few other systems like yours where they've cracked the nut of translating fee-for-service into global capitation payments. And as you said, it's usually by driving your cost down more than your revenue so that you actually have a margin that's related to that. You've increased your services and your team size while reducing your panel size, I think, to get what Toyin was alluding to of being able to have fidelity with what you're not only promising but delivering on without leveraging the professionalism of your workforce, which is what produces a lot of burnout when you don't have that kind of support for fidelity. And I'm sure Kelly would love to translate this to the Ohio model and the National Pediatric Network too. The question that I'm driving towards is coming back to Toyin. Toyin, how have you been able to do similar things? I really appreciated your description, but can you give us more depth of how you've been able to build your model to produce fidelity? Do we lose Toyin?
I'm not sure she's rejoined. I know she had to step away.
Oh, sorry, I missed that. Well, sorry about that. I wouldn't have driven straight to Toyin if that was the case. Kelly,
well,
I guess my question, please. And then I'd like to give that question to Kelly, what he sees here as a potential to model for them. Please, Doug.
Oh, sorry, I thought you were going to Kelly. No, I just in somewhat response to that, I think that as you were summarizing our story, a lot of the criticism people get, why doesn't everyone do what they've done in this organization, in South Central Foundation? Well, because it's daunting. It's a complete rethinking of the entire system. Specialists have to change. We use 30 to 40% less labs, less x-rays, less pharmaceuticals, because if you're in relationship with same-day access and trust, and you do lots of things virtually, people demand way less lab, pharmacy, and x-ray. Because if you have to take off of work and go across town and do this massive investment in a visit, then you darn well better do some labs and x-rays and give me some medications. I invested all this time and effort and energy. Instead, if it's a virtually present platform that never leaves your side and you can interact with it whenever you want to, then you're happy trying a little bit of at-home stuff or a little bit of time or using some advice for some self-care things instead of lab, x-ray, drug, because that's all modern medicine has time for, and frankly, it's all they know how to do anymore. And so the huge savings here are in reducing the cost, reducing the use of really expensive things. But also people look at us and say, Doug, most expensive primary care system in the world, look at all those people located in primary care. And the answer to that is 95% of them exist in the system. They're just separate islands, disassociated somewhere else with all these referrals and handoffs and all this discontinuity stuff instead of pulling them right into where they need to be to actively participate in the conversation in real time. So this is so much of the stuff I've heard all day today from other people doesn't question the fundamental paradigm of how the whole thing is its philosophy and its structure. And if you change the premise of what you're trying to do and then consider all assets available to deliver what's needed and recenter around the people and how they live their lives, you got plenty of assets and you don't need as much revenue.
So Kelly, just quickly, is that something that could be replicated in Ohio for caring for children? You're on mute, I'm sorry. Okay.
Oh, I actually have to, can you hear me now? I have my phone on. Not hear that?
We can hear you.
Okay, I see thumbs up. Okay, so bottom line is we are trying to integrate from a different perspective. We are trying to convince the providers, the clinicians, that we can make their lives better through relationship by integrating our systems into theirs so they can be more present and we can bring our services there. We take our chronic care coordinators once a month out to some rural practices to do tube care and technology care for all the kids that are home on different things. We offer, I agree, it's drawing more expertise into the primary care setting. That's why we're using Project Echo to try to keep all the behavioral health care integrated within the practice. And the practitioners want to do that. They actually end up enjoying it once they feel they have the expertise. And once we pay them a little bit extra on the side to keep the patients there. So the system has to be an integrated system that can act from the top down, not from the practice level, but we're doing the same thing from the reverse end as a regionalized pediatric specialty system, pushing care out into the primary care practices.
So next we have up Chris Caller and then Linda.
Thank you. Dr. Eby, this is a question for you. Since you addressed my first one of if it's so great, why can't other folks do it? And what I hear is the challenge of changing the fundamental premise of what you guys are about, or what's the business that we're engaged in. So I'll go to my backup question, which was, what in the 25 years of work, what public policies have facilitated your work and hindered them? You know, what are the key public policies to focus on? Thanks.
Yeah, so let me just answer both. So as people hear about us and they come and visit us and look at us and hear our story, most specialists don't like us because we're completely threatening to how they do their business and to their massive incomes and all that kind of stuff, because they work on a salary. They do much more of their work virtually. They're supporters of the hub instead of their own separate islands optimizing their profits and life to their liking. So most specialists don't really like us. Pharmaceutical companies hate us. Labs and X-ray people and so forth don't like us. Hospitals don't like us. We haven't added a single hospital bed in 25 years because we just keep pulling work out and out and out. So we threaten profits for hospitals and threatens for pharmaceuticals and specialists and all of these people. And this is really, really hard. You have to question people's central paradigms and belief systems that they spent decades accumulating what they think is the truth. And we challenge that truth. So it's threatening to pretty much every dimension of modern medicine, which is the biggest reason why people don't just adopt it. But the community, people, patients, families, policymakers, payers love us and think this is the way healthcare ought to be. We have a lot of fans in high places. Don Berwick calls this the future of modern medicine and all kinds of stuff if you're at a policy level and so forth. So from a public policy level, the problem is still the money, right? I mean, the way things are paid is increasingly fragmented and increasingly subject to diagnosis codes and procedure codes and so forth. So the best payer we have is the Indian Health Service, because we get money in essentially a block grant, and then we have to provide reports and accountability for what we've accomplished. And that's, of course, the perfect world for people like us, because we're actually beholden to the community. The community owns us. The community is extremely pissed off if we don't produce the goods. That's who holds us accountable. But the ability to be flexible with money and so forth, we just need to be held accountable, produce the clinical outcomes, produce the screening and prevention, produce the happiness and satisfaction, measure our readmission rates to the hospital, measure our hospital days per congestive heart failure person, measure our hemoglobin A1C control and so forth. But don't micromanage us. In healthcare, policy level, payer level, government, Medicare, Medicaid is just tighter and tighter, ratcheting down rules. Thou shalt do it this way, or you won't get our money. And then we'll send auditors in and audit the heck out of you to where you spend all your time chasing your tail, following rules, and getting audited, instead of being held accountable for outcomes and happiness and satisfaction and things like hospital rates and readmission rates and all of that sort of thing. Does that make sense? I mean, our experience of the last 10 years is just ratcheting down by payers, more and more audits. We just, we spend such massive time and energy being audited constantly, like every healthcare organization is. And then, we get glowing reports and they say, wow, you're amazing. And then the next month it's another cycle. I believe in coordinated single payer systems, but locally controlled, integrated, aligned delivery systems. And like I said, European countries and single payer systems are actually the most interested in us. They tend to have great social support and great hospitals and specialists, but even all over Europe, they have wimpy primary care.
So are your feelings of accountability greater to your formal governance structure, or once you get past the patients, the individual patients, are your feelings of what's a stronger accountability mechanism? Your organization's governance, or some sort of a public government structure? What makes you jump higher?
Right. So we have a corporate governance, but they expect every single location we divide. So this kind of ties in with Toyin. By the way, I'm a massive fan of Toyin. I think she walks on water. We ought to just do what she says. But the fact that Toyin's whole approach is very place-based and community-based and community accountable, that's the same thing for us. So every village, every town, every community where we're active, we have an advisory council of very empowered, powerful, energized people. And our governance tells us those people must be happy and you must spend tons of time with them. If you get deeply into Baldrige quality worlds, by the way, whether it's manufacturing or government or healthcare or anything that Baldrige is applied to, they tell you that one of the most important things is obsession over the customer, obsession over the consumer. What do they want? What do they need? What's working for them? What's not working for them? We exist for their benefit. So our technical governance is then backed up by layers and layers of accountability to advisory councils and local people with power and importance and so forth. And then that's again compounded by the same thing as Toyin said. About 65% of our workforce are directly from the community by design. It used to be 15%. We're now at over 60% customer ownership employment in our system. So, and we tell our employees, we don't want any distance between your family and your loved ones and your work. In fact, that should be top of your mind as you're in your workplace. So truly consumer controlled, consumer staffed, consumer owned, consumer driven, consumer accountable at every level.
Great. Thank you very much.
So Linda, you're next.
Thank you for a fantastic panel. And I think the reason why we have this statement of task before us is that these three outstanding exemplars are what we are calling innovation versus standard practice. And so our charge as the committee is to glean what we can from the stories you've shared with us, and look at what's preventing our country from moving forward. And so I'd like for each of the panelists to respond to that. But the other thing I wanted to have you respond to is, Doug, you talked a lot about training your workforce. And I wondered, a charge of this committee is to look at the workforce demands. And do any of the three of you have partnerships with educational institutions that are educating future providers to practice in the model that you need, that you want to hire them into? Or do you have to start from scratch? Do any of them come with you knowing this model and what you're doing? Or are you totally on your own to train the workforce? So two questions there.
Toyin, are you back?
I'm back. Sorry about that.
Go.
Sure. I'm happy to. So the first question on sort of, actually, do you mind, Linda? Just the first question was about kind of what are the barriers to us doing this more broadly?
Like if you had to name the top 2 or 3 barriers to why have other groups tried to replicate your model and it not worked? Like, what are the major, when we think about implementation, if we were to say, here are 3 models that we need to adopt across the United States, have you tried to do that? And what stops other communities from doing what you've done?
Yeah, I can give some thoughts. So on that, I think fee-for-service medicine has been continues to be just a major barrier, and a real challenge to overcome, where, most primary care is still delivered in a structure that is so closely tied to fee-for-service and so razor thin on the margin side that providers really struggle, I think, to invest in innovation, to radically transform, and then to move away from that place-based, volume-based model of care. So I think that's one. The second is, I think we're still pretty nascent. I love hearing from South Central Foundation in particular, because theirs is one of the most evolved and most tried and tested models out there. But many of us are still early on this journey. And so I think the one thing that we have learned is that there is no single playbook that people can take from one location and replicate elsewhere. And so part of the challenge is that I think, healthcare has a very, biopharmaceutical cognitive model for thinking about research and development and innovation. You test something in vitro, in vivo, it works on most people, and then you just disseminate. But humans are complex ecosystems, and they don't work that way. And what we're trying to do is build sustainable systems for massive scale behavior change for people with really heterogeneous needs in very different social settings. There is no single playbook that works. And so we have to rethink about our concept and our notion of implementation in this space much more around co-design. And co-design as a tool and as a set of tools and as a set of processes that enables communities to figure out what works for them, and then scaling and replicating that process. And so I think that there's a cognitive barrier there as well. And then finally, I do think that there's a workforce issue. I think that, and that it's a workforce issue, and that concretely it is that we have too few of the right skill sets in the right humans doing the work in healthcare, and too many perhaps of others. So, but really what it is, it's about power and hierarchy and history, and the notion of the physician as the, white coated center of healthcare delivery, who acts effectively in isolation and who has ultimate autonomy and responsibility for having all the answers for all of the needs of the person in front of them, versus the notion that a largely not clinically trained, entirely not clinically trained, often with less formal education, team of community-based and field-based individuals may have something meaningful to offer to delivering health outcomes is a massive cultural shift in the way that we think about healthcare. And so we have a workforce problem in that, like, the adoption of community health worker models, community health oriented models, and really the empowerment of those individuals to drive the change that they need to on par with the physicians is heretical to the way that we've set up the medical hierarchy. And humans don't give up power readily, and they have not been. There's been no incentive structure to force people to give up that power and to think about collaborative care in the way that we think it needs to happen. And so I think that's been a major barrier. And then it ties to your second question about kind of what are the workforce constraints. Then there, I think we're still we're still nowhere near where we need to be. And I think actually the hardest part has been, to my earlier point, has been retraining physicians and advanced practice clinicians to practice in a really different way when they come to work with us, to leave the white coat behind, to be on first name basis with everybody that they encounter, to listen to and value and appreciate the perspectives of others, to learn how to provide primary behavioral health and think that it's their job, to really, really learn to meet people with empathy and with respect on their own terms. It's tough. It's not innate to the way that we're trained to practice. And I don't think that, certainly my experience is not that medical education is churning out people like this in droves yet. So I think that there's a real thing on the formal medical education side that we need to solve for. And then honestly, on the community workforce side, Shreya is just the expert. I wouldn't really dare to even comment too much here. But there's a science to this, and I know she will tell you that. And that science in her world has been evolved and iterated over many years, and continues to be disseminated. I think we're really early in our understanding of what makes a really good community health worker as an industry, and the adoption of those best practices. But it's heartening to know that there are people who are taking this incredibly seriously and contributing to our understanding of that workforce in particular.
Right.
Thanks. So I have 4 people queued up. So just so you know, it's Tumani first, and then Shreya, Lucy, and Rebecca. Tumani, are you there?
Yep, I am. I was waiting to see if the other panelists were going to answer Linda's question. But I can go to mine. So thank you for really, the 3 of you, for really a thought-provoking and I think really important discussion. I really appreciated it. My question is really about the care teams that each of you discussed, and kind of as we think about the implementation of integrated care teams and the different ways to do that. And I'm sure that one size won't fit all. But can you talk a little bit about sort of when you see that care team, and this I think applies to that diagram that Doug showed with the primary care team in the center, and then the circles going out. And then to Kelly's point about bringing the chronic care coordinator from the system into practices. So this idea of how the care team can be set up, this integrated team, is it in what ways or what types of team members need to be kind of at the practice and focused locally, versus when do you decide to have that from a system perspective, as in the model that you're discussing, Kelly? So it's I think that's kind of where I'm thinking is how does that implementation look versus locally and on the ground versus the services from a system-based integrated care team model?
So for us, it's quite a bit varied by the location, and particularly by agreements among the providers. So for example, some of the providers in the rural communities have agreed to send all their G2 patients to one practice because our G-tube coordinator goes down there once a month and meets with all the patients at the same time. Or in Ironton, we have a group of autism families that all come together in the evening when a practice is closed for common psychotherapy with the psychotherapist in Columbus who's on telemedicine. So practitioners have found innovative ways to either keep their offices open or partner or share patients in a way that as a network they all benefit from. And the same is true with our ECHO project, where they're developing local expertise on treatment of ADHD or treatment of hepatitis C. And so when that can happen, there can be coordination, but it doesn't happen within one person's office where you can say, this is the team. It happens as a group. A group of practices in an area will say, this is what we need for support, and how do we set this up? So it's a negotiation, but when you have good relationships over time, that's not hard to do.
So this, Doug, I will come back to that. I just want to support and echo what Toyin said first to the earlier question. She said it, I've said it, I just want to reemphasize it, that the single biggest barrier to doing this, to doing better things, is this massive loyalty and adherence to the what she called the biopharmaceutical, what I call the medical model, and the disintegration of humanity into specialty and subspecialty and centers of excellence and all of that. It's ridiculous. If you listen to Toyin's model and our model, they're place-based, they're community-based, they're whole family and community structured. You're no longer the diabetic or the autistic or the whatever. You are a human that's in partnership with a bunch of people who bring a ton of expertise to try to help support you on that journey. So the core problem is what is pervasive in what's taught in every professional school that creates modern medical professionals. It's just wrong. It works for 1/3 of what we do, but it does not work for 2/3 of what we do. And let me just give you one very specific intervention we did that's been transformative. So the other thing Toyin mentioned was competence in other skill sets, and she's mentioned behavioral health and ability to connect and motivate people. So 10 years ago, we decided we needed to help our clinician mentors be better mentors. So we found this organization that did professional coaching of executives. They had never worked in healthcare, but they were very successful outside of healthcare. We brought them in. We've ended up working with them for a long time and then gradually bringing it in-house ourselves. So now all of our clinical people who are in any kind, well, just tons and tons of our people have gone through what we now call a coaching curriculum. And it was based off of this mentor stuff. And again, don't have time to go into all of this, very constrained time, but we've now put hundreds of our staff through this. And what they learn how to do is the actual technical skill set of really effective coaching. So I'll just take a doctor, tells me after this, they tell me, you know what, Doug, I now know how to mentor other doctors. I'm like, great, that was part of the purpose. And he says, but you know what? I'm also way better with my clinical team. I'm much less the doctor in control. I'm much more the facilitator, the partner, the team person. So I'm better with my clinical team. And he says, you know what? I also can manipulate my manager now because I know how to do that better. And I'm way better on the phone and in the exam room because it turns out 80% of primary care is really coaching, and really outstanding teaching and learning and skill development around coaching makes me a way better clinician. And by the way, my marriage is in much better shape. And those teenagers that live in my house, I actually know what to do with them now. And so it turns out it's a basic human skill, life set sort of thing that helps you in all dimensions of relating to other humans. But that is the core of what we do. We are a service industry providing a messy human interactive product. And the core of that is the messy human part. And yet the amount of training in all of our, whether it's a nurse training or a PA training or a pharmacist training or a doctor training, you get a little bit about behavioral health, but not very much. And you sure don't get deeply developed skills on coaching, advising, cheerleading, mentoring, which it turns out is the fundamental core of what primary care is, as we've heard from all speakers all day long today. And the sophistication and knowledge in that arena of our professionals is horrible, horrible. So yes, we do have to invest massively in retraining and reskilling our entire workforce for this work, which is sad, which then goes to your follow-up question around education and teaching in our professional schools and that kind of stuff. They're terrible. All they do is teach you the medical model. By the time you're out, you have a complete belief in that particular paradigm, which is full of assumptions and biases and prejudices that are not overt, but they're certainly baked in. And we have to undo all of that and then replace it with a whole nother different skill set. So there's huge work to be done there. We have concentrated on the last stage of training. So internships, fellowships, residencies, those kind of things as our best return on our investment, because then they come and work directly for us after completing those things. We were asked to write a white paper on the future of medical schools at one point, and the fact that our first sentence was that medical schools as they currently exist should be destroyed meant it didn't get a lot of wide play in academia. But I deeply believe that, this idea that orthopedic surgeons that replace knees need to spend 4 years in a common curriculum with psychiatrists who work with manic depressive disorders is insane. It's completely nuts. So it's just, everything's wrong with how we organize and select professionals and train professionals and so forth. So thank goodness they do have good medical diagnostic knowledge and skills, and they do learn how to use pharmaceuticals well, because that is important. But that is not the fundamental skill for primary care, which we have to completely retrain.
Great. So Shreya was next.
Thanks for these awesome presentations. It strikes me that we're hearing the same thing through different lenses and facets. So I would like to ask the speakers and also the group to crystallize what we think are the core components to some of these successful programs, recognizing that in reality across the United States, not everybody's going to get this perfectly right. There's going to be a spectrum from, an ideal setting to, the dysfunction that is our reality. What are, 5 or 6 key things? Like what I'm hearing are, number one, very simple outcome metrics and not complicating that piece. Number 2, simple, somewhat global payment. Number 3, assigning one role per practice environment to sort of own the relationship. Number 4, a strategy for doing that is basically getting people's life story and turning that into tailored care plans. And number 5, nothing else, like no prior auths, no process metrics, no crap. So that's like my proposal for what our report should be. I don't know if I'm supposed to talk about that yet, but we need to make this operational, and we have to design it for dysfunction. So what are the key things we can pull out from these models that are scalable?
Doug, I like your list. It's great. I like how you're distilling. I think you missed a huge one that at least Toyin and I would be obsessed about, and I think Christine would also be obsessed about, and that is that your workforce ought to look like the people you're trying to influence, and that ought to be maybe the number one demand. Because if we're in the business of influencing people to lead better and healthier lives, to take their medications, to do the difficult things that we ask them to do, the people best able to influence people to do that are people who are most like them. So for primary care, especially in particular, your workforce needs to be from the community you're trying to influence, needs to look like them, culture, ethnicity, beliefs, values, how they use words and communicate, because you have to have trust and influence if people are going to do the difficult work it takes to be healthier and change habits and all of that. So one of your top 10 must be your workforce has to be from and look like and be like the people you're trying to influence. Toyin, I think you'd agree?
And there's some irony that I missed that.
I don't know you well enough to comment on it, but I'm pretty strong in the opinion.
She lives and breathes it, so I know. Yes.
I like the rest of your list. I think the other one you kind of had on there, but maybe just add a little more. I think another common theme in places at work, and I think all three of us speakers right now, including the pediatric speaker, is the team idea, the team, and much less doctor centricity and so forth. Multi-skilled, multi-dimensional, multi-capable teams, and the behavioral health, coaching, partnering ability built into those teams. Yes?
Great. So we have Lucy and then Rebecca, and then we'll try to wrap it up and get to our public session.
So thank you all. My question is going to build on Treya's question and the question that Linda asked earlier about implementation. And it seems to me that so much of what you're talking about is successful contextualization to your local communities. And I was hoping you could talk a little bit more about that from an implementation perspective. You know, rather than models that we're applying with fidelity, what are the principles for successful contextualization? And you've talked about co-design, local accountability. You've talked about retraining and reskilling of the workforce for coaching and teaming. You've talked about having a workforce that matches the community. But if you were going to take your care models and move them to a new community, what would be the most important things that you think that you should do, you know, aside from the ones that I've already highlighted that you mentioned?
I guess I'll start. The thing that I would say, and you know, one thing we haven't talked about this morning or this afternoon is actually the greed that's involved in medicine. And in particular, you know, I've presented our model to other children's hospitals around the country, almost all of them, as a matter of fact, individually, and many of their CEOs have toured our neighborhood, work on housing development and neighborhood employment, some other things. But several of them said, if we do this, we'll make, you know, we will be risking our income. And we are making so much money right now with these contracts, why would we want to change? When we go out to rural areas and say, you know, let us help you hire a lot more peer models and a lot more parent coaching and a lot more community health workers, the physicians say, am I still going to make as much money? Primary care docs included. That's the first question everybody asks. So I'm not saying we don't overcome that sometimes, but I think in the long run, we have to tell people physicians are not always going to make as much money as they do now. If we're going to be honest, there's not enough money in the system for doctors to give baby shots and crawl around the floor with babies and still make the amount of money that they do. So I tell people, we're not going to lie, we're going to tell you the truth. And some people, that upsets them. So I do agree, but our system to go in has to be able to say, what's the best possible way to do this in this community across all these providers? We have to share savings with child custody and child welfare to keep kids out of foster care. We have to share savings with the jail to make sure kids don't get in jail. So we sign contracts with all those agencies and say, we want to keep kids at home with their families in the right place, no matter who the provider is. And it may not be a physician all the time. So that's a challenge that we have to overcome. And so we tend to round up a lot of support in the community before we start with the physicians.
Doug, I would. Oh, no, go ahead, Toyin, go.
Sure, I'll be really quick. The only thing I would add is the partnerships with community-based organizations. And you know, as you enter in a into a market, so as a healthcare provider, you enter into a community or market, people think about like, Who am I going to refer my cardiology patients to? Who am I going to refer people for my joint replacements that need to get done? And so you build this network of like downstream providers. Rarely do we think about building high value referral relationships, true relationships with community-based organizations, where they have access to bidirectional information flow, where we're holding them accountable, where we are really, really partnering to make sure that our patients, our members, our communities get what they need. And so that's a key piece for us as we enter into a new community, is understanding who our partners are going to be on the community-based service delivery side and making sure that we value them in a relationship so that they can continue to sustain and do what they need to do.
Went to community partnerships. So I was going to go kind of the same place Toyin just went to: community partnerships, community platform, community accountability, and networking, and all of that kind of stuff. I think Kelly's got a good point on the money side. I said at the beginning, modern medicine is, our healthcare is messed up by two big things: how money is handled and the complete adherence and loyalty to the reductionistic mechanical medical model. They're both very, very true. In the U.S., most of the conversation has been around the money. So I tend to spend all my time talking about the over-reliance on the medical model because I think it's just as big and not as recognized. But the money is certainly a huge part of this. We view, our opinion, our community's opinion is pretty much all healthcare dollars are public dollars, because Medicaid and Medicare certainly are. Social Security is, disability money is, that's all public money. But even employer-paid health benefits we view as public money, because it's a big amount of money for the benefit of a large number of people who do not have individual choice. Therefore, it is a community asset delivered by an employer. And so if you add that in, you're at 95% of the money being a community asset. And if we start to demand that that be the case and get payment policies that treat it that way, then you start to be able to manage the money piece and you start to be able to manage the greed. So yes, the money part, I completely agree with Kelly. That has got to be fixed along with the other stuff. And then the other one thing I just want to, that's been mentioned just tangentially a couple times, but was really mentioned earlier, was this business of transitions of care and the fact that all this fragmentation, which gets to the money piece, which is all this fragmentation, every different piece optimizing their bottom line and their own personal greedy profits instead of some kind of centralized control and coordination around money, referrals, and so forth. So the idea, I actually hate the word patient-centered. I hate the word co-creation. I hate the word medical home because of what they've all come to mean. And I'm happy to explain that if anybody wants to understand. But the idea that our institutions are someone's home is just offensive. It should be patient-driven and patient-controlled, not patient-centered. And co-creation usually means we let a couple of patients into our holy sanctuaries, but on our terms to talk about our structures, which is ridiculous. If you're really going to do co-creation, we have to go out into their environment, their lived reality, and adapt our services to their lived lives and what works for them. And so most of these terms they're headed the right direction, but they're little tiny incremental movements forward. So just the final point on transitions, if the primary care platform remains present in the person's life everywhere, all the time, you reduce by like 80% the problems with transitions. But that means you have to continue to be present through specialists, through hospital, through nursing homes, through everything. You never are not part of the conversation. And that's the other piece, that's the other plank to the platform as you define it, is the always at your present, trusted expert, knowledgeable, partnering. But that doesn't have to be the doctor. That has to be the organization, but it has to be people they know. But it can be lay workers. It can be lots of different people. But that function has got to occur. And then just one final thing. We have a lot of pediatricians. I like pediatricians, but we've turned them into pretty much child experts supporting broader oriented generalists, community members, more whole person, whole family generalists. And just one final point there, one of the worst things we do on transition is we do all this work in primary care with people, and then they get pregnant. And what do? We send them to someone else for their pregnancy, just at the time they're actually making lifestyle decisions around diet and exercise and alcohol and so forth. And then the baby comes out, and then we do another transition. Well, that's dumb, because one of our biggest opportunities in modern life is pregnancy. People get excited about pregnancy and births and new babies. We should be leveraging the heck out of that, but as part of a lifelong journey, not as something separate. So when we talk about early childhood interventions, we go back to preconception and conception as the beginning of that conversation, not the day that they're born. And there's just stuff like that we do that we just take for granted in modern medicine that's just completely dumb if our job is to be the platform and relationship with people through a lifetime, and having maximum influence at opportunity times like pregnancy and birth and other exciting and difficult times in people's lives. So,
Doug, thank you. So we really literally only have 1 minute left, and Rebecca, I apologize. This means your question doesn't get into the conversation right now. Sarah, I think you had input from questions from at least 3 public members to give to the committee to consider as we go into closed session.
I do. I have 3 questions and also a comment. I'll start with a comment. This person says, a lot has changed since patients were discussed in the last report, let alone Barbara Strifield's work, communication, access to information. I hope that this committee can deeply consider these developments and resist the impulse for professionals to decide what the system should look like. Moving on to the next question. Not much was mentioned about what value, if any, nurses play in primary care in addition to providers, even more specifically, bachelor's prepared nurses. Do any of the presenters or committee members have any comments or insight into the utilization of this staff and their scope of practice to assist in improving with care delivery? Speeding through. The next one, could you explain how clinicians and staff are trained to function in what appears a different approach to care delivery? This is for Dr. Eby at South Central. And 2, could you describe how you engage and obtain feedback from the consumer patients you are serving? And the last question was, how do we serve, patients with more rare diseases such as congenital heart disease? I can see your models would work great for CHD, but one problem we have encountered is the lack of access to specialist care. And that's it from the public.
I think I don't want to treat any of these as trivial because they're not. I think our conversations about how patients have changed and their expectations is very relevant and very much on our agenda. Nursing, again, not to belittle it at all, I think has been conceptualized as part of the team. And if we look back at the second Future of Nursing report, which was really an evaluation of the first report and its outcomes, we could really lean on that because you actually cannot measure the nursing workforce in primary care. It's actually impossible with the data sets we have, but HRSA had estimated to be less than 5% of the BSN and RN workforce. So it's a critical question for us to address because they are such important team members. But we should definitely take that into consideration as we have our discussions this afternoon. I really want the last question about the access to specialty care for patients, particularly coming out of primary care and health centers, as was described. I just wonder if quickly, Toyin or Doug or Kelly, do you have any insights that you haven't already offered about that? Not just the difficulty, but any solutions you found that we should be considering?
Well, this is Doug. I spoke to that one quite a bit, and it's a fervently held thing of ours that the specialists and what's happened with specialists and this quotes problem of access to specialists is a huge part of what's wrong with modern medicine. So I already said a lot about it, but I just would add this piece that by doing it the way we do it, we need about half as many specialists as we would otherwise need. So the difficulty access to specialists is actually largely solved if you have massively powerful, capable primary care, and the money doesn't get in the way of reorienting how specialists in primary care connect with each other in support of the person.
I agree with Doug, and I think we offer, we don't divide it up as specialty or not specialty. We have roving pediatric ultrasonographers who go down and provide congenital heart disease care in Southeast Ohio. We have EKGs that are sent in from rural hospitals that are distant in. We have parent support groups that are online. And then we encourage primary care docs to be in direct contact with the referring physician, who always tries to provide a same-day communication about when they're seeing a clinic in specialty care. So it's not just, is there congenital heart disease, for example, care? It's actually a whole series of types of care, and most of them are integrated geographically.
Well, I really want to thank our panel. Toyin, Kelly, Doug, thank you so much for your input today. You gave us a lot to chew on. To our committee, we're scheduled to come back to order at 3 o'clock, so you have about 15 minutes for a break. Linda, any last thoughts before we break, or? I didn't mean to put you on the spot.
Linda, you're on mute.
I'm sorry, I was muted. Just a fabulous panel, and thanks again. You've really given us a lot of food for thought, a lot of ways that we can shape our report and our discussions going forward. I can't thank you enough. So let's take our 15-minute break. Okay, everyone?
Thank you.
Thanks.